Good, eve- good evening. Good evening and welcome you all to the Eizoc webinar Voice of the East. Today's theme is Cornea Revisited. I welcome you on behalf of the host state Jharkhand and extend my special welcome to the President, Secretary, Chairman Scientific Committee of Eizoc. I also welcome Dr. B K Sahay, the senior most Eizoc member of Jharkhand, who will be felicitated today. I also welcome the keynote speaker, the Doyen of Ophthalmology, Professor Rajesh Sinha from All India Institute of Medical Sciences, New Delhi. I welcome the moderators, Dr. N Gupta, Dr. P Kashyap, and Dr. Sunil Kumar, who will be moderating the session today. I welcome all the 6 speakers who will be participating and enlightening us with their scientific talks. Like Dr. Ravi Daulat, Dr. Rakhi, Dr. Praveen Subudhi, Dr. Janakar Medhi, Dr. Nidhie Kashyap, and Dr. John Sarkar. And before I hand over the podium to the President, I would like to play the video of Eizoc. So now, to begin the opening ceremony, I would like to request the President of Eizoc, Dr. Abhijit Ghosh, to give his welcome address.
Thank you, Sujoy. Thank you so much. It's always been wonderful to be in part of this program. I welcome you all to this edition of the Voice of the East, the live webinar program organized by Eizoc and hosted by the Jharkhand Society. I like the topic very much, Cornea Revisited. Revisiting and research are part of our progress in life. So friends, this program has been now very nicely accepted everywhere and has become a regular curriculum. I laud the activities of the wonderful team which we have in Eizoc, headed by Pranav, for this wonderful effort. This program has been implemented with a definite cause, I suppose. We have a dual cause. One, to regularly interact with each other. Every 14 days, I am seeing the faces of N R Subudhi, N Gupta, Pranav ICA officer, and a lot of faces I can see. That's great thinking, and we are together. And the second is to give a podium and a pedestal to our junior colleagues to showcase their activities. But we have an interest also. As Pranav will say later, we want to increase our membership. So it will be a request for our junior members, please join Eizoc to make it a more comprehensive society. This time, this edition, we have come up with a novel idea to respect our senior colleagues, it is basically not a form of felicitation. It is just a question of recognizing and respecting our seniors and to see them speaking and coming within us and join our program. This is the reason we want. So let's enjoy. Before I end, I can reiterate that Eizoc is becoming stronger day by day, and I have been amazed by the coordination and the togetherness we have seen in the last GB meeting of the AIOC also. Let us give a momentum and enjoy Eizoc together. Thank you all.
Thank you, sir. Now I request our Secretary Eizoc, Dr. Pranav Ranjan, to give his report.
Now you unmute yourself.
Welcome and good evening to the 5th edition of Voice of East and the 6th during COVID times. Thanks to the President of Jharkhand Ophthalmic Society, Dr. Halimuddin, the Secretary, Dr. Bibhuti Bhushan, for gracing the scientific platform. Welcome to Dr. B. K. Sahai, sir, advisor to Eizoc, who will be recognized today later on in the program. Special thanks to Dr. Rajesh Sinha, Professor RP Center, All India Institute of Medical Sciences, Delhi, and the Treasurer of AIOS for accepting our request to deliver the keynote address. Our mission to extend Eizoc to every corner of the East and make it accessible to every member stands validated today. By January 2021, we will be completing one full circle of 12 beautiful states that we have. We also take this opportunity with the consent of the President, Eizoc, Dr. Abhijit Ghosh, to offer a 25% membership discount to all the attendees of this webinar. This offer will be valid for 2 days. Members who want to take up membership can log into eizoc.in. We have an online facility. And one more special announcement I have to make, that on the 29th of November 2020 at 3 p.m., we have the special GB meeting, and I'll request all members of Eizoc to please join that special GB meeting. Before I hand over the whole screen to for the scientific program, I would just like to take you down the memory lane of Eizoc. The golden journey of Eizoc started in the 70s of last century. Objective among ophthalmologists of the East was to come on a common platform. Initiative was taken by Dr. L.C. Datta, Dr. A.N. Pandya, Dr. U.C. Behera, Dr. M. Lala Singh, and Dr. K.R. Datta. Professor Ranbir Mukherjee took the lead role in formation of the society and its constitution.
So would you like to show your slides?
The slide, you cannot see or what?
No, sir. Please share your slides.
I think I'll just read out this thing if this is not coming.
Okay, no problem.
Or just hold on, because I just want people to understand and know the history of Eizoc.
Okay,
And
no
photographs
please,
also.
Please go ahead.
One second. Is it visible now or not? Is it visible or not?
Sir, it is
No,
not
it's
visible.
not.
Please
No,
go to
not
share
visible.
screen,
Okay.
the green button.
Not sharing the screen.
No, I'm sharing the screen. Anyway, one second.
Actually, हाँ जो join है sir. Actually silent mode में था, मुझे पता नहीं phone कब बज रहा था. Sure.
Video and audio.
Right, sir, radio audio. Sir, background नहीं आ रहा.
Okay, forget it. I mean, there's a glitch here. So I'll
No
just
problem.
yeah,
Please go ahead, sir.
I'll just read out that. The second one is more important, right? So,
Yes, sir.
yeah. So I was with the history of Eizoc. The first Eizoc conference was held in Calcutta in 1985 under the leadership of Sri Mohan Mishra from Bihar. Eizoc was formally inaugurated and constitution drafted by Dr. Ranbir Mukherjee adopted in the general body meeting. Professor Sri Mohan Mishra became the first president of Eizoc, and the office and the Congress was in Calcutta with Dr. Ramendra Lal Shah as the secretary and Dr. Chandi Lal as the treasurer. Thereafter, regular annual meetings started being held in different parts of the East. Media conference was started by the vision of Dr. B. N. Gupta in 2016. So this is all about the history of Eizoc, and today we are going to have a fantastic evening. All the best to all the speakers, all the panelists, and all the viewers. Thank you.
Sujoy, you unmute yourself.
I would request Dr. Debashis Das to present his report. Dr. Debashis Das, Chairman, Scientific Committee of Eizoc.
Good evening, everybody. I hope my slides are visible. Are my slides visible, sir?
Yeah.
So basically, we have an opportunity which we should capture upon. The Voice of the East. This is basically a fortnightly evening online programs designed by the scientific committee as well as the executive committee of Eizoc, and is on the every alternate Wednesday evenings. There will be alternate 2 academic programs followed by 1 secretarial program. The responsibility of the academic programs will be given to 1 state at a time, following down in alphabetical order. The state in charge of the academic program will put their main thrust on the younger generations than on the established speakers and the academicians. And the state organizing the academic program will keep half of the speakers from their state and the remaining half from the other respective states. We will include lectures, debates, quizzes in this evening program. We started with a neurolinguistic programming by Sudeep Sinha, who is one of the mind trainers and peak performance wellness coach in Calcutta. And thereafter, it was followed by the schedules which we had followed down the line. On 7th October, we had in Assam. On 21st, we had Bihar. On 4th November, there was a secretariat program on investments and emergencies. Today, we are covering Jharkhand. And thereafter, we have a series down the line. From today onwards, we will start a new tradition of felicitating our senior members of the host states during the webinar. Initially, we will felicitate advisors of the respective states, and this will be then followed by other senior members. Tonight, we will be honored to felicitate Dr. B. K. Sahai. With this, I conclude my talk and proceed for the next session.
Thank you, Dr. Debashis.
Thank you.
Now I would request our President, Dr. Abhijit Ghosh, and Secretary, Dr. Pranav Ranjan, to felicitate Dr. B. K. Sahai, one of the senior Eizoc members of Jharkhand.
Good evening, sir. Okay. Sir, could you unmute yourself? Unmute, please.
Dr. B. K. Sahai, sir, please unmute yourself.
Unmute.
करना है आपको
Yes, yes, sir.
ना बोलिए गुड इवनिंग हेलो
Good evening, sir.
गुड इवनिंग सुनाई पड़ा
Yes, sir.
Pranam, sir. Pranam, thank you, sir.
प्रणाम
Doctor, sir, we are just honored to have you with us, and we hope to felicitate you. Dr. Pranav Ranjan will say a few words, sir.
ओके
Dr. Bimal Kumar Sahai, he is fondly known as Dr. B. K. Sahai. He was born in Saran, Bihar. He did his MBBS in 1967 from Prince of Wales Medical College, Patna. MS in 1972 from Patna University. Diploma in Ophthalmology in 1981 from Patna University, FICS in 83. He was a senior resident in PMCH, registrar in NMCH at Patna. Subsequently, he went on to become the assistant professor of SKMCH Muzaffarpur, MGM Medical College. He was associate professor of RIMS Ranchi. He went on to become professor at Rajendra Institute of Medical Sciences. He was professor and head of High Tech Medical College at Bhubaneswar, professor and HOD Raurkela Medical College. He holds a Lifetime Achievement Award, which was bestowed to him by Eizoc, Special Award by Ranchi Ophthalmic Society, past president of Bihar Ophthalmic Society, East India Zonal Ophthalmic Congress, Ranchi Ophthalmic Forum, and he has been a managing committee of All India Ophthalmical Society. We are greatly delighted and honored to have you here on the platform, sir. This is an honor from Eizoc and all members of Eizoc for the contribution that you have made for this society. And society acknowledges you, and people like you, we always look forward to for advice for whatever we are going to do in future also. So with these few words, I would like Dr. B. Kashyap, sir, to please speak a few words on this golden moment.
Thank you so much, Dr. Pranav. Thank you. I'm really.
This is a bunch of rose, sir, from Eizoc family, sir.
Oh, thanks. I'm thankful to the President, Secretary, and executive members who remembered me for felicitation. I'm associated with Eizoc since many years. I've seen the bad days of Eizoc. When the Eizoc boat was sinking and it was being pulled by Dr. S.C. Das. During that period, Dr. S.C. Das had developed Eizoc phobia. He always talked about Eizoc only. He is a good friend of mine. He always used to call me, but he never asked about my welfare. He started with the talk, 5 member बनाइए या 2 member का पैसा दे दीजिए. On a repeated call, I deposited 2 membership in Eizoc account, and then after I was really scared of his call. Don't mind Dr. S. Das. Thanks to Dr. Debashis Bhattacharya, who came for rescue in this crucial period. He arranged a special meeting of Eizoc during the Disha CME in Kolkata, which was attended only by 8 to 10 members. I was one of them. It was decided to increase the membership, hold CME, and to bring members together. Thanks to Dr. N Gupta, who started vigorously in this drive, contacting Eizoc members, making new members, arranging midterm conference, and bringing the members together on Eizoc platform. Thanks to our colleague from Northeast who joined this drive wholeheartedly, making new members, holding midterm conferences, and now we can see the Eizoc graph has moved very fast in upward. I named the Northeast for their contribution. It will take much time, but I cannot complete my talk without naming Dr. Silchar, to whom I handed over the charge of President Eizoc. For his contribution, he strongly advocated for holding independent Eizoc conference, and he arranged it in Silchar with good hospitality. I pay my respect to the active members from Patna, late Professor J. N. Rohatgi, Professor N. Pandya, Professor A.S.V. Sahai, Dr. V.N. Prasad, and Dr. K.C. Mehta from Ranchi, Dr. Panna Lal, Dr. Partha Vishwas from West Bengal for their contribution in Eizoc. Today, I remember and pay homage to 2 Eizoc warriors, late Dr. Ranjan of Patna and late Dr. H.R. Mohanty of Bhubaneswar, Ursa. Now, under the able leadership of President Dr. Abhijit Ghosh, Dynamic Secretary Dr. Pranav Ranjan, Active Chairman, Scientific Committee Dr. Debashis Das, and energetic executive, the Eizoc has gained much height with time to time advice from Chief Coordinator Dr. N Gupta, Dr. Biraj J Goswami, Dr. Surinder Singh, Dr. Arvind Jaiswal, Dr. J G Agarwal, Dr. Satyajit Sinha, Dr. Swaraj Bhattacharya, and Dr. Nagendra Prasad. Just now, our President said that it is a wonderful society. Really, I feel it is a wonderful society. From Secretary, I heard that in last webinar, it was attended by around 2,000 members. Wow, what a good response. I have taken much time. Though only 2 minutes time was allotted to me, before ending, I will suggest and request all the members to unite together and fight AIOS election jointly. Then only we can have our say in AIOS. Thanks once again for remembering me and honoring me. Long live Eizoc.
Thank you, sir. Thank you, sir. We are gratified. We are blessed. Thank you, sir.
Thank you. Thank you so much, sir.
Thank you, sir, for those kind and motivating words. Now we'd like to move to the scientific part of our program. For this, I would like to invite the Chairman, Scientific Committee of Eizoc, Dr. Debashis Das, to introduce our keynote speaker, Professor Rajesh Sinha, who is from RB Center, New Delhi.
May I request Dr. Pranav Ranjan to unshare his screen, please, sir. Thank you so much. It is our honor to have Dr. Rajesh Sinha with us today. The Professor of Ophthalmology in Cornea, Lens and Refractive Surgery Services at RP Center, AIIMS. He has done MD in Ophthalmology from AIIMS and then did DNB, FIACLE and FRCS and did a fellowship at the University of Washington. He has 354 publications, 4 textbooks, and 5 educational manuals to his name. He has been a part of 3 multi-centered FDA clinical trials. He has received various awards, notable among which are the Achievement Awards of AAO, APAO, and the SARC Academy of Ophthalmology, and has been appointed the Professor of the Asia Pacific Academy of Professors in Ophthalmology. Recipients, and he is also the recipient of many notable orations in the country. He is currently the Treasurer of the AIOS, Treasurer of the SARC Academy of Ophthalmology, General Secretary of the Indian Society of Cornea and Refractive Surgeons, and the Treasurer of Eye Bank Association of India. With this, sir, may I invite you, sir, Professor Rajesh Sinha, to deliver your lecture for us today. Thank you, sir.
Thank you.
1 minute. Can please everyone mute yourself, please. Many sounds are coming, lateral sounds, please. Okay.
Thank you, Dr. Debashis, and I'm extremely thankful to Eizoc as I'm a part of Eizoc. Basically, can you see my slides?
Yes.
It's visible, sir. Please go ahead.
Visible, sir.
Since I'm very much a part of Eizoc, it's a very emotional moment for me, speaking in front of my own seniors. I'm from Patna and part of Eastern India. And speaking with my own family members, I can see Abhijit Ghosh sir, N Gupta sir, Dr. Sahai sir, Dr. Jaiswal sir, Dr. Pranav, Ranjan sir, Dr. Kashyap sir, Dr. Subudhi, Dr. So many other people, my friends, Dr. Sujoy, Dr. Bibhuti, all these are, Dr. Bharti, all these are, people from my own family. So for me, it's a very emotional moment. And that is why I felt that I should speak something to which I am very emotionally attached also. And I've been working in the field of keratoconus for quite some time. And I thought that maybe it would be a topic about which I should speak. So once again, I would like to thank everyone from Eizoc, my own family, people, and we'll start my talk on keratoconus advancements in management. Now, any advancement means that it's a clinical entity. So any advancement means that what are the advancements in the understanding of the disease and what are the advancements in the treatment modalities. And I'll be basically focusing on these. So keratoconus is a progressive non-inflammatory bilateral ectatic corneal disease which causes thinning and ectasia of cornea and causes irregularity of the cornea resulting in visual loss. So basically we have a progressive disease which causes irregularity in the cornea resulting in suboptimal vision. So that is why the aim of management will be to arrest the progression and to provide visual rehabilitation. And in order to have a better understanding of the disease, we should detect it. In order to have a better management of the disease, we should be able to detect it at its infancy, at its earliest level. And that is why early detection is very important. And early detection is done only by various means. Of course, we all are clinicians, and I'm fortunate to see some of the seniors who have contributed so much in ophthalmology. And so they all diagnosed the condition because they all had highest degree of suspicion. So early detection can be done only when you have highest degree of suspicion for any disease, and this suspicion is based on certain symptoms that a patient says and based on topography in case of keratoconus. So what symptom a patient will tell you when you have a suspicion that this can be keratoconus? Now somebody who is complaining of frequent change of glasses. Now frequent change of glasses at the age of 55 to 60 or 50 to 60 will mean that probably he is having either cataract or having open angle glaucoma. But somebody who is reporting frequent change of glasses at the age of 15 years, 18 years, 20 years, it can be because of myopia or because of keratoconus. And somebody who says that in spite of correction by glasses, his visual acuity is suboptimal, this means that there is some irregularity and we have to investigate, and this may be a case of keratoconus. Now, there are certain investigations that we do, and the modern investigations, obviously they are there, they are the recent updates, but there are certain things which are already established and we may not emphasize much in many of the talks, but refraction or retinoscopy is something which is very essential. It will give you a scissoring reflex, and the moment you get that, you can understand that this is a case of keratoconus or oil droplet reflex, something like that. Then topography, which started with the Placido disc base and now has moved on to tomography like slit scanning, Scheimpflug or OCT based imaging system. So earliest detection is the most important thing which actually is done by the updates that we get in the field of managing a case. Now Placido based topography gives you the idea about the anterior surface of the cornea. And there are certain signs like malalignment of Meyers or loss of Meyer parallelism. And there are certain criteria like if the central corneal power is more than 47.2 diopters, there is inferior superior asymmetry, oblique astigmatism with asymmetric bow tie pattern, you can see here, with a skewed radial axis. Now asymmetric bow tie pattern once again is a very common mapping pattern of cornea. But if the axis is skewed, like if the long axis of this lobe and this lobe has an angle of more than 21 degrees, that is highly suggestive of keratoconus. Then of course came the slit scanning methodology of tomography, which was the first tomographic method, which gave the quad map wherein anterior elevation, posterior elevation, and curvature map and the pachymetric map were assessed along with the vital indices. Now, vital indices, if you have an astigmatism which is high, which is oblique, which is having a very steep keratometry, that is suggestive of keratoconus. Now this is an example wherein you are getting a keratometric astigmatism of 1 diopter and it is 44.7, and it is against the rule astigmatism or with the rule astigmatism. Then in that case it is unlikely to have a case of keratoconus. Now, if at 3 mm zone the irregularity index is more than 1.4 and at 5 mm zone the irregularity index is more than 1.9, then that suggests keratoconus. So this is not a case of keratoconus as shown in the vital statistics. But when you go to the posterior elevation, then the posterior elevation is high. If any elevation more than 60 in the OBSCAN map, then in that case, it may be suspicious of keratoconus. So this may be an early case of keratoconus with a earliest change seen in posterior curvature. Similarly, now we have pentacam, which gives you the curvature map, anterior and posterior elevation map, and the pachymetric map. Now, going into details of all these maps will take a lot of time. But what I would suggest here, what I will tell here is that it is having this sort of a same sort of thing. Only thing is that in pentacam, the values are different. Like if the anterior elevation is more than 12 microns and the posterior elevation is more than 17 microns. And at one point, if the difference between anterior and posterior elevation is more than 5 microns, then it is suggestive of keratoconus. And if in the Bell-and-Em ratio enhanced ectasia display, you can see these red points in the map, the progression index is quite high, more than 1.2. The ART max is 41 only. These are all suggestive of keratoconus. So I won't go into much detail of this, but these are now an established modality of managing or diagnosing a case of keratoconus. However, newer things are coming up, and this is a Corvus that is biomechanical, that gives you a biomechanical stability, wherein if a cornea is not showing a map which is highly suspicious but still having some weakness, then you may suspect that this patient can go into full-fledged keratoconus at a certain date. And if the CBI and TBI are suspicious, if it's more than 49, 50, then it is suspicious. So these things we have to understand, although it is coming up. Another thing that is coming up very fast in terms of diagnosing case of keratoconus is epithelial thickness mapping on anterior segment OCT. Now, if the anterior segment OCT is suggesting that the epithelial thickness map is giving low thickness in the inferior part, inferiotemporal or inferionasal, in comparison to the superior part, this means that this patient may not be having all the topographic criteria of keratoconus at this point of time, but this patient should not undergo a corneal refractive procedure, and this patient needs to be followed up for keratoconus. So as you can see here, another case wherein the inferior epithelial thickness is lesser than the superior part, that is suggestive of a suspicious cornea. So these are some of the advancements in terms of understanding the disease. Now, coming to the management part of keratoconus, we have to arrest progression and we have to provide visual rehabilitation. So let us see what is established in arresting progression and what is coming up now, which is getting established. Now, progression means that if the Kmax value is more than 1 diopter, if the difference between Kmax and Kmin is more than 1 diopter, and if the pachymetry is showing a decrease by more than 2% in central corneal thickness over a period of 6 months, this means that it is progressing. Now, if it is progressing, then corneal cross-linking is an established modality wherein you debride the central part of epithelium and then you put riboflavin and then you focus UVA rays onto the cornea so that you want a better cross-linking of corneal collagen to have a strengthening of the cornea. So this is what is being done after epithelial debridement. Riboflavin is put every 2 minutes and then for 30 minutes, and then you focus UV rays for 30 minutes. And this is the conventional Dresden protocol of corneal cross-linking. And results have shown, the studies have shown very good outcome in terms of stabilizing the corneal curvature. And demarcation line is something which, this is the demarcation line. This is, you can see here, it is at the level of 231 microns. This is at the level of 220 microns. So this presence of demarcation line is suggestive that corneal cross-linking has worked. But there are certain issues in terms of corneal cross-linking. One, when you debride epithelium, there is pain to the patient. Then it's a long duration procedure. It's a 1 hour procedure. And then if the cornea is thin, lesser than 400 microns, then if you expose the cornea to UV rays, the endothelial cells will get damaged. So updates have come, the advancements have come in order to satisfy these things. Now, people, in order to keep the epithelium intact and not to have pain, people have done transepithelial cross-linking. But now most of the studies have shown that transepithelial cross-linking is not very effective. So we have, the punchline is this, that in any case, we have to debride the epithelium. This is the current established modality. And there are some other things that are coming up, which I'll talk a little later. Then in order to reduce time of the cross-linking, which is 1 hour, people have done accelerated cross-linking. This is based on Bunsen law, which states of reciprocity, which states that the total value should be the same. The total energy should be same. So if you are using 3 milliwatt per centimeter square for 30 minutes in conventional cross-linking, if you make 30 milliwatt per centimeter square, you just have to use it for 3 minutes. So this is the total energy that is delivered to the cornea. So based on that, people started doing accelerated cross-linking. Then various studies have been done on this. And obviously, initially, there is always this kind of a feeling that, accelerated works. But then people compared conventional cross-linking with all the modalities of accelerated cross-linking. And they found out that the 9 milliwatt per centimeter square for 10 minutes is the accelerated procedure, which is comparable to the conventional technique. And that is what we follow these days. So this is something which has come up now, and most of the people are following this accelerated cross-linking. Another thing is that if the cornea is thin, that people have tried using hypoosmolar riboflavin to swell the cornea, and they have also used bandage contact lens in order to have a distance of endothelial cells from the UV rays. However, all these modalities are there. They have some effect, but they are not as good as conventional cross-linking in a normal cornea. So in thin corneas, what we have started, and I've done a study, given a thesis to one of my candidates. The idea is to insert a lenticule into the cornea so that the corneal thickness increases, and then you do cross-linking. So what will happen, that the UV rays will be away from the endothelium, and you will also provide tectonic support. So this is femtosecond laser assisted creation of pocket. Now, you can see this is the dissection with the femtosecond laser, and then a side incision is made, vertical incision is made. And then the pocket is created by opening up of this dissection, and then you inject the pocket and also onto the surface. And then what we do is that we use a lenticule which is created with the help of a donor tissue. What we do is that we take a donor tissue, first cut a cap, and then invert it, and then another cut, again make a lamellar cut, so as to create a 200 microns and this lenticule is inserted into the cornea. So intrastomal implantation of lenticule is done. So it provides tectonic support, increases the thickness of the cornea, and then you can also do cross-linking over it, so as have a good effect of the. So this is what it is. So we have done the study, we have completed it. This is how it looks like on day one, the intrastomal lenticule. And then, of course, the demarcation line has been shown to be deeper into the cornea. So the results are quite good, but there is some limitation in this. We have used the 7mm lenticule, and in some peripheral large cones, it creates some issues. So I have designed another study wherein I'm planning to go for a larger lenticule. So we will definitely be analyzing this study, and we'll come to the final data and final outcome. Then customized cross-linking is something wherein people have used more energy in the area of cone and lesser energy in the surrounding cornea in terms of UV rays energy. So this is customization of cross-linking, and the initial results are showing good results. Another thing which is coming up, and I have also started this study, there's an animal study that has been done by Theo Seiler group, and they are also doing human study, and I'm also doing at RP Center. We are using oxygen to increase the cross-linking. Why? Because what normally happens that in a normal atmospheric oxygen has 21% of oxygen, and in the stroma, in the middle of stroma, it reduces to 13%. So, and when we use UV rays, it becomes 0. So if we can supplement oxygen, then there will be more oxygen in the stroma. So what we will get, we will get more of singlet oxygen, because what we want singlet oxygen so as to create a covalent bond between the collagen fibers. And we don't know what is going to be the result, but we are doing this study at RP Center as well. I have myself given a thesis to one of my students. As far as the visual rehabilitation is concerned, in very early cases, you can give spectacles, then contact lens, and then of course surgery. Now, as far as contact lens is concerned, bicurve lens, Soper design, and multi-curve lens of Rose-K design are the ones which are popular, and the end point of fitting, as shown in this small video clip, is a 3-point touch, the central touch, and the 2 mid-peripheral touch. So it's a 3-point touch, good centration, movement, and coverage of the contact lens, and that gives a good visual rehabilitation. So but there are some patients who are intolerant to RGP contact lens. So you can put a soft contact lens over which you can put an RGP. So it provides comfort to the patient, the soft lens, and the RGP provides good visual outcome. So in some patients, you can use a piggyback contact lens in order to get good comfort as well as visual outcome. Hybrid contact lens is meant for the same. It has a peripheral soft skirt and the central RGP part. So it provides good visual outcome as well as comfort. And in cases of large cones, you can give a mini-scleral contact lens in order to cover that large cone, or sometimes in keratoconus with PMD, in such cases, you can give a mini-scleral contact lens to provide good visual outcome. Intracorneal ring segments have been used with good results. They have been combined in cases of keratoconus with cross-linking. What it does, it shortens the intracorneal ring segment, shortens the arc length and flattens the central part of the cornea. And then over that, you do cross-linking. You remodel the cornea and then stiffen the cornea. Now, this is a femtosecond laser which is being used to create the passage for the intact segment. You open the radial incision first, and then you open up the initial part of the track into which this segment is introduced on both sides, and then you introduce this segment. So this is the intracorneal ring segment that is being introduced into one side, and then again it will be introduced onto the other side. And once you have introduced on both sides, you put a suture to close this radial incision, and then you debride the central epithelium within the intracorneal ring segment area, and then do cross-linking, accelerated cross-linking. So this is what is intracorneal ring segment along with cross-linking in some cases of keratoconus. Now, this is the ASOCT image on day one. Now, sometimes what happens that this cross-linking and intracorneal ring segment can be done. However, some patients do have issues in terms of high refractive error. So you can put either put the patient on a mini-scleral contact lens, or you can also do a toric phakic implant. So this is a phakic implant which is being introduced. The cornea is marked, the axis is marked, and then you go ahead and place the, I'm just going a little fast due to paucity of time, and I'll just finish in 2-3 minutes. So this is the toric phakic implant, which is being placed and the axis aligned, and so it works well. I'll just give you one example that somebody who is having a very high astigmatism, there was a case wherein I had a very high astigmatism of 8 diopters, wherein first I placed the intracorneal ring segment, so the astigmatism reduced to 4.5, and then I could place a toric phakic implant, because you can't put a toric phakic IOL in a high astigmatism of 8 diopters. Keratoplasty is the last resort. Initially, when it started, we used to do full thickness graft in all the cases of keratoconus. So whatever be the case of keratoconus, you enter into the anterior chamber, do a full thickness dissection, and then put viscoelastic and put a donor lenticule and suture it. So this was the established modality. But what people understood with time, that keratoconus is a disease wherein the endothelium of the host is normal. So why not preserve it? And based on that, people started doing lamellar keratoplasty. And in lamellar keratoplasty, the big bubble technique of lamellar keratoplasty is the one which is preferred in cases wherein you don't have a corneal scar, and you create a big bubble which is pre-desmetic. You dissect the partial thickness stroma, enter at the level, pre-desmetic level, the air escapes, so you can see, you inject viscoelastic so that the desmase is pushed behind so that you don't damage it. And then you cut the stromal tissue, you have retained the host desmase, you remove the donor tissues, desmase and endothelium, and then place it, and that it completes the surgery. However, there are scenarios wherein you do have a central scar in the cornea, as you can see in anterior segment OCT. In such case, you have to do a layer by layer dissection of the corneal stroma so as to do a anterior lamellar graft, maximum depth anterior lamellar keratoplasty. If you do a big bubble DALG in such case, then it's a case of healed hydrops wherein there's a desmate scars, so it will open up and then you will not be able to complete the procedure. So layer by layer dissection is done. And the recent update is the advancement is the use of intraoperative OCT to know it helps you intraoperatively to know at what level you are dissecting. Suppose your dissection of the bed is thin on one side and thick on the other side, then you can make it uniform so that post-operative quality of vision is not disturbed. Sometimes what you get is that you have dissected everything, but you get a small ridge in the center, which you can see here in the intraoperative OCT. So you just dissect this ridge so that in the end, you get a nice uniform posterior lamella over which you place the donor lenticule and suture it. Just a word about acute hydrops. If there's an acute hydrops, earlier we used to manage it with hypertonic saline and topical steroid and cycloplegic, but these days we inject intracameral gas, and which is an established modality for quite some time now. The intracameral gas is injected in order to seal the desmate's rupture, and then supportive treatment is given in order to have the clearance of this edema because of the hydrops. So in conclusion, keratoconus is a mysterious disease of cornea. We are learning a lot even now. We are doing some newer studies, but still these are all based on masking the irregularity and providing visual rehabilitation. The actual treatment will lie on gene therapy, but there are limitations on gene therapy because there's not a single gene which we have to treat, because in multiple cases we have seen multiple gene loci involved. So it becomes very difficult to do gene therapy, and that is why that limitation is there. The current management is based on detecting it as early as possible so that we can restrict it at that level only by stabilizing it, by doing cross-linking, by newer modalities of cross-linking. In thin corneas, we have limitations, so we are coming up with the newer modalities to how to stabilize the cone. And of course, to mask the irregularity, we can do either cross-link, we can use contact lens, RGP contact lens, which can have various designs, or we can use intracorneal ring segment or a combination of ICL, etc. And in the end, we have to do keratoplasty, and anterior lamellar keratoplasty is the keratoplasty of choice in cases of keratoconus. So thank you very much for your patient listening, and taking a couple of minutes extra.
Thank you, Dr. Rajesh, for this. next part of the session.
May I, sir?
Sir.
May I ask a question, please?
Please go ahead, sir.
Dr. Rajesh, a wonderful paper, and I learned a lot of things. I have been doing C3R since long, and I have a few questions. Suppose if you suspect a case of keratoconus, and which is not materialized even after doing a lot of investigation like on topography and the oculizer and all that. So what is wrong in doing C3R in a suspicious case? What do we lose? That is number one.
By suspicious case, you mean to say that there is no evidence on topography?
There is suspicious evidence, and even the oculizer is a borderline, and the patient has problem. Patient is symptomatic.
Symptomatic in what sense, sir?
In the sense that the power of the glasses are increasing, the patient has distorted vision. And one thing, what I have seen during my examination and my experience, that apart from other symptoms, the patient are peeping toms, meaning thereby patient कभी ऐसा देखेगा तो हाँ अच्छा दिख रहा है, ऐसा देखेगा अच्छा दिख रहा है, सामने अच्छा नहीं दिख रहा. So at particular point the patient sees better. This is a very, very strong suspicion of keratoconus. Very, very strong suspicion. And I have detected few cases just because of these symptoms. So these symptoms keeps on increasing, then I feel that this is a very strong suspicion and I should do C3R. So what if I do the C3R in these cases? What do we lose?
Nothing, sir. If a patient is telling that he's having fluctuation of vision, then in that scenario, I'm 100% sure that by using the current modalities of diagnosing, we will get enough evidence to state that it is a case of keratoconus. And once it's a case of keratoconus, it depends on what age that patient is on. See, we are not losing out on anything if we are doing cross-linking in these cases. Now, if a patient is, 18, 20, 16, 24, and he's giving just a subtle sign on topography, small sign of topography, of keratoconus on topography, giving history of some fluctuation, I think we should go ahead and do a cross-linking. Now, if the same patient comes at the age of 32, 33, then we may not think that, at the age of 32, if he has come up with this minimal evidence, that then it is unlikely to progress. So cross-linking, the basic idea is to flatten the cornea just by 1 or 1.5 diopters. Maximum it corrects the astigmatism. What it does is that it flattens the steep keratometry, and because of coupling effect, there is steepening of the other axis. So the astigmatism reduces. So whenever a patient is complaining of fluctuation or ghosting of image, it is mostly because of astigmatism that is present in keratoconus. So there is no harm in doing cross-linking in such cases. We should do cross-linking. Only thing is that no two cases is the same. We have to judge based on so many things. Somebody reporting to you for the first time, what we know, direct evidence of progression, then only we should do it. But somebody who at the age of 16 is coming to you with a thickness of 450 microns or 440 microns, this means that the thing has progressed to that level from 500 or so. Although the patient did not come to me, but he at the age of 14, his keratoconus will not have a thickness of 450. So in that case, even in the first sitting, if the patient has come to you, you can do cross-linking. So there are multiple factors that we have to understand in case of keratoconus, and I fully agree. There are a couple of reports of keratitis following keratoconus, following cross-linking. So people do get scared. But if you have a direct evidence, definite evidence, and you can justify that this patient definitely has progression and will have progression because of younger age group, we should do cross-linking immediately in that case. Not even wait for a definitive evidence of progression, particularly somebody who is reporting with a slightly higher parameters of keratoconus even at the age of 14, 15, 16. So that case is progressing. So we have to do it. And if there is subtle sign, as you said, that complaining of fluctuation, complaining of ghosting of image, not improving with glasses, this is a sign of keratoconus. So I don't think there is any problem in doing cross-linking.
Thank you. That answers my question. Thank you very much.
Cool.
Any more questions?
I have a question.
Yes.
So in these cases of keratoconus, young age, if the patient comes and the first visit, so will you like to follow up for a certain period, say 4 months, 3 months, or you will straight away go for this? Because most of us in the private practice, we don't have corveas to assess the biomechanics of the cornea. So in that case, what would you do?
See, Corvus is not the only tool. It is just an upcoming tool, which is a supportive tool. I won't say that Corvus is something which will guide, your cross-linking, right?
There are a lot of discussions that all the cases of keratoconus, they don't progress. So you keep them in follow-up topographically and refraction-wise.
Keratoconus is such a mysterious disease that the best of scientists have not been able to understand it. And so many things we keep doing and we evolve with time. Now, as you said, that somebody who has come to you for the first time,
yes,
what I wanted to convey is that somebody who has come to you for the first time, he is 16 years of age, having a corneal thickness of 490 microns with a little bit of astigmatism, little bit of complaints. You can keep reviewing the patient every 3 months with, topography and with etc. But somebody who is coming to you, for the first time, 16, 17, 18 years of age, with a thickness of 435 microns,
then you have to do
astigmatism. This means that the patient has already progressed to that level. And at the age of 16, 17, 18 or 20, if he is having a thickness which is just the borderline level wherein you can do cross-linking without adding anything, I mean, there's no harm in doing cross-linking at the first, at the first time when the patient comes to you to show to you, because such patients will definitely progress. They will definitely progress. So these are all, our teachers, so many seniors I can see here who are here, who have taught us the skills of clinicians. So we are clinicians. So we have to understand, we have, in investigations, it is written that these are the findings and you have to corroborate clinically. So corroborating clinically is very, very important.
You can't afford to wait much in these cases.
Yeah, somebody who is coming to you with an advanced keratoconus, first, although he may not be showing it to anybody, but coming to you with a thickness of 435, 440, high astigmatism, irregularity, not improving with glasses, at the age of 18 or 17 or 18 or 20, I mean, this means that it has progressed to that level.
It depends. Even if the weather comes for the first time, it depends on the topo and the refraction state.
Absolutely.
Based on that.
Sir, one very practical question, sir, if you allow.
Yeah.
So, what is your experience in repeating the C3R?
Repeating the C3R?
Yes, sir.
Sir, repeating the C3R, usually, one can do it after a long period, because maybe after 3-4 years, if again it is progressing, that is one. But repetition should be done only in cases wherein there is some response in the primary treatment. Because there are some cases who do not respond to C3R also. So in those cases, if we repeat, it is not going to help. And this is not based on my own experience. This is also based on comments and studies done by Farhad Hafizi and others. So what they have told that repetition, Farhad Hafizi has done repetition in a very short period, over a period of 2-3 months only, in order to have an additive effect. And he found that there was an additive effect of a repeat cross-linking. Some people have done repeat cross-linking after 3-4 years of time. But the common point is this, that those who respond to cross-linking in the primary, in the first treatment, they will only respond to your second treatment. So repetition, repeat cross-linking should be done only in those cases wherein there is some response in the primary treatment.
Why I asked this question was because in our experience, after the C3R, the corneal thickness, it decreases and it's not even maintained, it slightly decreases. What is your experience, sir?
will decrease because there is cross-linking. There is compactness of the cornea. So because of the compactness of the corneal thickness will reduce little bit immediately after some time of cross-linking. But it will remain, it will maintain. And another thing that will give you an idea whether the cross-linking has worked or not, that is based on presence of the demarcation line on ASOCT. If you can see the demarcation line, that gives you a vague idea. And although there is no definitive evidence, but this gives you an idea that cross-linking works in the anterior two-thirds of the cornea. And that is why the demarcation line you see is at the level of 250, 260 or up to 300 microns of the corneal stroma. So if you get to see a demarcation line, it means that there is cross-linking at work. Second thing is that if there is some flattening, some reduction in astigmatism, this means cross-linking has worked. If you see that there is some reduction in thickness immediately after cross-linking, this means there is compactness, so cross-linking has worked. And if you see that over a period of time, 6 months, 1 year, there is no progression, this means that cross-linking has worked.
Thank you. Debashis, I think.
Thank you so much, sir. Please let us go ahead with the main session. Thank you so much.
Dr. Debashis, may I intervene? Dr.
Yes,
Sujoy, can we
Yes,
have
sir.
a word from President Dr. Halimuddin and Secretary of JHOS?
President Dr. Bibhuti. Dr. Bibhuti was.
Yeah, Dr. Bibhuti.
Yeah.
Yeah, right.
Few words of motivation from them.
Yeah, because they are the special invitee. So after that, we move on to the main speakers. So can we call upon the President,
Dr. Halimuddin, sir, please.
Please, for a word of wisdom, followed by Dr. Bibhuti, and then straight to the scientific speakers program. I think he's there or not?
Dr. Bibhuti was there. I've seen it.
Yeah. Hello, can you hear me?
Yeah.
Yeah, this is Dr. Bibhuti.
Yeah.
Thank you, the President and the Secretary of Eizoc for inviting us. It's a wonderful webinar that we are attending, and we just now had a fantastic talk by Professor Rajesh Sinha. It definitely helped us in making a few corrections in our decision making in the OPD when we are seeing patients with a potential keratoconus. Thank you, Professor Rajesh, for a fantastic talk. And it is a wonderful webinar, and I think without taking much time, once again thank the Eizoc Executive Committee for inviting us to attend this webinar. Thank you, sir.
Thank you, Dr. Bibhuti. And whenever Dr. Halimuddin joins in between, we'll take a bite from him also. So over to Dr. Sujoy.
Yeah, so now moving ahead, I would like to hand over the podium to the three stalwarts who will be moderating the session, Dr. N Gupta, Dr. P Kashyap, and Dr. Sunil. Just to remind, Dr. N Gupta will be moderating Dr. Ravi Barbhaya and Dr. Raki. Dr. P Kashyap will be moderating Dr. Praveen Subudhi and Dr. Mehdi. And Dr. Sunil Kumar will be moderating Nidhie G Kashyap and Dr. John Sarkar. After that, there will be a panel discussion which will be done by Dr. N Subudhi, an icon from Odisha, Dr. Bharti Kashyap, a prolific LASIK surgeon from Kashyap Eye Hospital, Jharkhand, and Dr. Sudhir Kumar from NMCH Patna, and Dr. M Agarwal from Shankar-Deva Nethralaya is also there to enlighten us. So over to the moderators.
Thank you, Dr. Sujoy. We are going to have a very wonderful webinar today. As we all know, cornea is the most important layer, I will say the gateway of the eye, which contributes almost 40 to 45 diopter of the refractive power to the eye. It usually remains quiet, but it's very sensitive to outside trauma or the trauma within the eye in terms of inflammation or say surgical insult. In the field, we come across usually many cases. Sometimes it's very perplexing and very difficult to treat, like corneal ulcer. In the field, agricultural injury or industrial injuries or any other causes, we do get corneal ulcers. In spite of all the efforts, many a times it becomes very difficult for us. So it's a very good webinar today on the topic of the cornea, and the meticulous examination of the cornea is what is needed, and that therefore it needs visiting and revisiting the cornea, and that's why the name has been given Cornea Revisited. We have got a panel of very good speakers, I will say our generation next, who are doing wonderful work on the cornea, and they will enlighten us on the corneal conditions. The first speaker is Dr. Ravi Barbhaya. I would like to invite Dr. Ravi. He is actually, he has done his MBBS from Thiruvananthapuram, MS from Baroda. After that, he did FECO fellowship from Shankar Nethralaya, Chennai. He did his long-term corneal fellowship from Shankar Nethralaya, Chennai in 2012. And after that, he joined Shankar Nethralaya, Kolkata as an associate consultant in the cornea and refractive services. Since 2018, he has been in private practice at Jamshedpur and doing excellent job. So with all these words, I invite Dr. Ravi to give his talk. Dr. Ravi, please.
Yes. Thank you, sir, for the introduction. And the topic that I'm going to, I hope if people are able to hear me.
Yes.
Yes, great. The topic for presentation today is the case of congenital corneal anesthesia. Now, at the onset, I would like to thank the organizers for giving me this wonderful opportunity. I have nil financial interest. I would like to acknowledge the Cornea Department, Shankar Nethralaya, Kolkata, for the clinical pictures. I want to present a case history of a 3-year-old female baby from a poor socioeconomic background who was
you have not shared the screen.
Share the screen.
Yeah, sorry. It's clear?
Yeah, it's correct.
Okay. Case history is a 3-month-old female child from a poor socioeconomic background, and she was referred for both eyes epithelial defect. The parents had complaints that the patient developed white spots and discharge in both eyes since the age of 1 month. The patient was a full-term normal delivery. The mother did not have any maternal illness or fever during the pregnancy. It was a consanguineous marriage. The elder sibling, which was a male child, 2 years, was blind, and the patient herself did not have any episodes of any self-mutilating injury. There was no history of any nocturnal lag ophthalmos. There was no history of any ocular disease in the parents. Immunization was appropriate for age. Parents were very specific that at the time of immunization, while giving the intramuscular injections, the patient used to cry, but there was no tearing from the eyes. There were no known systemic disease in the child, and the patient was diagnosed as congenital glaucoma elsewhere. She was on topical antibiotics and anti-glaucoma medications. Basically, patient had both eyes epithelial defect. And on examination, on general examination, patient was very playful and was not in any kind of distress. On indirect ophthalmoscopy, we could see that the lids were flat. There were no injury marks around the skin or the eyes. The blink rate was definitely reduced. The palpebral aperture was increased. The ocular surface was dry, lusterless, and there was a lot of mucoid debris. Conjunctiva had no congestion, but on fluorescein staining, there was diffuse staining of the conjunctiva. The limbal palisades were not very well defined. The corneal diameter appeared normal, and there was a large central epithelial defect in both the eyes, around 6 to 8 millimeters, and there was stromal scarring in both the eyes. Left eye had more stromal scarring, and there was no corneal melting or any corneal thinning. The anterior chamber was formed. Corneal sensation was absent in both the eyes, and the patient would not respond to pain stimuli. That is, the emotional tearing was grossly reduced. So, a clinical working diagnosis of congenital corneal anesthesia with neurotropic keratitis with keratoconjunctivitis sicca was made. The other things that I could think of in this case was herpetic keratitis, very severe vitamin A deficiency, Hansen's disease, so any abnormality of the trigeminal nerve like aplasia or a cerebropontine angle tumor, but all of them seem to be very unlikely at this age. So the patient was started on topical medications. The topical medications were preservative-free lubricating eye drops and antibiotic eye drops to prevent any secondary infections. Patient was advised for the splinting of the arm so that he does not injure the eyes by rubbing it, and tape tarsorrhaphy was explained to the patient. The definitive management included the doing of permanent lateral tarsorrhaphy under general anesthesia. A neurology and pediatric consult was also done. In this case, it did not help much because the MRI was normal and they could not identify any syndromic association. So basically, the patient underwent both eyes examination under anesthesia. There was epithelial debridement, the margins were freshened, and a permanent lateral tarsorrhaphy was done under general anesthesia. In this case, we splinted the arms, or basically the parents basically tied up the arms so that he does not touch the eyes or rub the eyes and injure himself. As far as the post-operative course is concerned, he was followed up every alternative day. The plan was to give lubricating eye drops, preservative-free, and antibiotic. The operation was pretty successful. There was increase in the surface moistness, the mucoid debris had decreased, and the epithelium was healing pretty well. But from post-operative day 7, that is at least 1 week post-op, there was clinical worsening because of the failure of the tarsorrhaphy. The tarsorrhaphy just opened up and there was an epithelial breakdown. Basically, by the end of the day 7, we were at the same spot, back to square one as it was at presentation. So what next in these cases? So definitely in these cases, the main problem is that it is a neurotrophic cornea. There is dryness, and in these cases, to heal the epithelial defect is very difficult. So we decided to go for all the modalities that are possible at one go, because it's a 3-month-old child and it is difficult to give anesthesia again and again. So in this, we decided to have both eyes epithelial debridement, do a punctal cautery this time, place amniotic membrane graft, though it seemed to be a little bit overarching, but because of the large epithelial defect, I decided that it was better to do amniotic graft to help in the healing, bandage contact lens, and then do both a permanent lateral paramedian tarsorrhaphy along with a temporary medial tarsorrhaphy. So basically, epithelial debridement was done, the edematous edges were freshened, and the base was cleaned. Amniotic membrane was placed with fibrin glue, and punctal cautery of both the upper and lower puncta was done so as to preserve the tears. Along with lateral tarsorrhaphy, permanent lateral tarsorrhaphy was done, and bandage contact lens was placed, and also a medial tarsorrhaphy, temporary medial tarsorrhaphy was done, which we plan to release later on. Post-operatively, the patient was doing fine at 1 month. The epithelial defects had healed in both the eyes. Definitely the sensation was absent, but the tarsorrhaphy held on. The right eye was much better than the left eye. The left eye had some scarring, but not much in the visual axis. So basically, wanted to discuss this case because it's a rare case, but it does come around. I see almost around 3 to 4 cases yearly. So congenital corneal anesthesia, complex neurological conditions characterized by neurosensory deficits involving the ocular surface and may extend to the other divisions of the trigeminal nerve. Now, the neurosensory deficit may occur in isolation as a part of the neurological syndrome, or may be associated with other somatic abnormalities and what is known as CIPA, congenital insensitive pain. When the patient has this congenital insensitive pain, then the patient is predisposed to self-mutilating injuries like chewing off his thumbs, chewing off his lips, tongue, and this is part of the syndromic association with the corneal congenital anesthesia. So in this case, this is a very nice paper published in the Journal of American Association of Pediatric Ophthalmologists and Strabismus by the LVP group. It's a very large series of cases in which around 68 eyes of 40 patients were studied. So in these cases, the duration mean time interval between the presentation and the diagnosis of corneal anesthesia was around 80 days, that is around 3 months. And the initial presentation, 40% of the cases had microbial keratitis, that is corneal ulceration. Redness and white spot was the most common symptom, and absence of tearing was present in 50% of the cases. The important thing is that the parental consanguinity was there in around 40% of the cases. So the clinical features that were present, most common was presence of epithelial defect and dry ocular surface. Ulcers was present in around 30% of the cases. Corneal scar was there in around 27-28% of the cases, and absence sensations in the ocular adnexia was present in around 25% of the cases. General loss of touch and pain sensation, that is insensitivity to pain, was there in 25% of the cases, and 30% of the cases had delayed milestones. So what was the management that was done? Topical lubricants was used in all the cases. 68 of all the eyes had been given topical lubrications, and 68 eyes had undergone lateral paramedian tarsorrhaphy. So the mainstay of treatment was basically lubricants and tarsorrhaphy. Repeat tarsorrhaphy, as I did in my case, was done in 4 eyes, and there was a corneal scar, central opacity in approximately 50% of the cases. Now, important thing to note over here is that keratoplasty was attempted only in 4 eyes. That is, 2 eyes underwent penetrating keratoplasty and 2 eyes underwent talc. But the failure rate was also, both eyes, all the 4 eyes failed, the PK failed and the DALC failed. This is because of the neurotrophic nature of this cornea. So the basic pathophysiology is that the spectrum of congenital corneal anesthesia depends on the timing of the insult during the embryogenesis. Ultrastructural studies have shown loss of unmyelinated and small myelinated fibers in the dorsal root ganglion. Anesthetized cornea have poor epithelial turnover and defective epithelial repair mechanism due to decreased levels of cyclic AMP, acetylcholine and acetylcholine transferences at the nerve terminals. So how to differentiate it from the common corneal hypoesthesia of the acquired variety? Now, herpes simplex, herpes zoster are the differential diagnosis. Corneal scarring, post-PK, long-term contact lens use, abuse of topical anesthetic eye drops, diabetes, leprosy, any irradiation in the head neck region, and compressive or infiltrative lesions of the trigeminal nerve. So basically the take-home messages are: poor vision, photophobia or congenital congestion, corneal ulceration in the absence of pain or distress in a child should always alert the clinician to the possibility of an anesthetic cornea. Ophthalmologists need to check the corneal sensation in all children presenting with bilateral corneal scars. Tarsorrhaphy is the surgical treatment of choice. You should consider punctal cautery to preserve the tears. Penetrating keratoplasty has a high risk of failure due to the neurotrophic component. It is best avoided. Optical iridectomy would be the surgical treatment of choice in case if you want to visually rehabilitate in cases of central corneal scar, because these patients will tend to have amblyopia with time, and patients will require lifelong care and follow-ups. Thank you.
Thank you, Ravi. I just wanted to know how long is your follow-up? When did you see the patient last, and what is
follow-up? Patient last more than a year.
More
than a year, and patient was actually, even after the tarsorrhaphy and this thing, patient does come back with epithelial breakdowns. So lubricating eye drops. Sometimes if there is some inflammation, I'll add some steroids, but the follow-ups are regular.
What I was thinking, that did he had a repeated epithelial defect?
Yes, ma'am.
That's what I was thinking. Did he had any repeated epithelial defect? You said.
Yeah. That keeps coming. They will have some epithelial defect because they might have some trauma. They might rub their eyes. So usually what the literature says, that as the person grows, then it is more easier that the patient will not cause trauma to himself. The parents will also be more alert.
So what medicines did you continue?
Lubricating eye drops.
Lubricating eye drops.
Lubricating eye drops. That is, and in case when there is an epithelial defect, always cover it with an antibiotic. And if I feel there is a lot of surface inflammation, I will add a steroid.
What was your frequency of lubricating?
Frequency. Lubricating was at least 8 times, and anytime SOS. Means anytime, I even say that whenever you're using a lot of computers or this thing, means the parents, when are there, you just keep using the lubricants even hourly. So if you say to the patients you use it hourly, they'll use it 6 to 8 times a day.
Dr. Ravi, what will be the lubricating of choice?
There was a time when we used to get this preservative-free like Refresh Easy and other drops. Now that is not available. So over a period of time, I have tried multiple combinations and now have shifted to hyaluronate-based eye drops.
Yeah, because
I'm Dr. Agarwal.
Dr. Ravi,
I'm Dr. Agarwal. Hello.
Hello.
Yes.
What is the relation with the other child who is blind?
Why don't you on your video, Dr. Agarwal?
Dr. Ravi,
Yeah.
what is the relation between this child and the other child who was blind?
Siblings.
Yes, now it's all right.
They were siblings.
Yes, I'm Dr. Agarwal.
Yes.
Yes, Dr. Agarwal.
Yeah, I have a. Did you try fibronectin drops, autologous serum?
No, sir. I did not try that.
So, do you think any role?
If I think that if it responds to simple tarsorrhaphy and lubricating eye drops, I would prefer that. And fibronectin, I have no idea because I've never used it.
Yeah, no, because there is a deficiency of your lot of vitamins and other so many things it contains. That is the reason I'm asking. Yeah. So normally, when we treat your neurotrophic keratitis,
correct.
That is one thing I'm thinking that if you can add, that might little help further.
Yeah. Problem with autologous, this thing is the availability and the sterility.
Dr. Ravi, do you think limbal stem cell transplantation will be a choice in these cases?
No, because the limbal stem cells are per se not damaged, not defective in this case.
Yes.
Doctor, one thing is that your study is unique. There are not many studies like this. I must congratulate you for this paper, and you have to follow it up, and then we'll learn a lot of things from you. Thank you very much. A great paper.
Thanks, Ravi.
Thank you,
we'll take up in other questions at the end of the session, if time permits. So, Dr. Sujoy, am I supposed to invite Dr. Rakhi or the next? Dr. Sujoy, please unmute yourself. Unmute. Sujoy, unmute yourself.
Dr. Rakhi is the next speaker.
You'll be introducing, sir?
Okay.
You introduce. After that, Kashyap sir will call upon.
I'm going to invite Dr. Rakhi Kushmes from Patna. She is an additional professor at RIO AIIMS Patna. She has done her MBBS from Allahabad and MS from Meerut, and then undergone short-term training at LV Prasad Eye Institute, Hyderabad. The area of interest are corneal transplantation, limbal cell transplant, limbal stem cell transplant, and ocular surface tumors. She has been awarded at AIOS and Keracon also, and she is guiding many projects, research projects and publication and book chapters to her credit. So with all few words, I invite Dr. Rakhi Kushmes. She will be speaking on topical chemotherapy of OSSM. So Rakhi, please.
Thank you, sir, for your kind words. First of all, I would like to thank Eizoc Scientific Committee for making me a part of this webinar. So I'll be presenting the topical chemotherapy for ocular surface squamous neoplasia. I have no financial disclosures. So I would like to start my presentation by asking you a question that what would be your mode of treatment for managing these two cases? One presented with the OSSN involving the 360-degree limbal stem cells and part of the cornea. And another one is a case of xeroderma pigmentosa and presented to us with recurrent OSSN and multifocal OSSN. So I'll get back to these cases again in later presentation. Before that, I would just like to highlight the salient features of OSSN. So this ocular surface squamous neoplasia is a clinical term that describes a spectrum of neoplastic changes to conjunctiva and the cornea, and it comprises of dysplasia of all grade, mild, moderate, and severe to carcinoma in situ and invasive squamous cell carcinoma. So the clinically diagnosis of these OSSNs are not very difficult. They are primarily clinical by recognizing this fleshy mass present on the conjunctiva, and they can be of various type, and they can be easily detected by seeing their morphology. Like they can be gelatinous if they're flat, slimy type lesions, leukoplakic when there is a presence of keratin plaque, and papillomatous, and the nodular. However, some peculiar features or peculiar clinical characteristic help us recognizing these cases easily, like presence of feeder vessels and intrinsic vessels, the presence of keratin plaque, and few stains also helps in delineating these lesions very finely, like rose Bengal staining, which stains the revitalized cells. And one of the very important tests help us in determining whether this lesion has invaded inside or not, that is a scleral fixity. And it is very important test to do with what kind of lesions you are dealing with. This does give you a gross idea. Other than that, the gold standard always been a histopathological examination in excisional biopsy specimens. And other thing, what we do in OSSN workup is that ultra ubium to rule out any intraocular extension. Nowadays, when everything is going to be shifted to this thing, non-invasive management, non-invasive imaging, and non-invasive treatment. So this high resolution OCT actually help us a lot for monitoring the lesions or for measuring the size of the lesion. So it gives the epithelial differentiation, epithelial thickening, or changes from normal to abnormal epithelium. So we can monitor these cases with the biopsy, this OCT. As far as management is concerned, then wide surgical excision with cryotherapy and post-operative metabolites is a standard treatment for these OSSNs. But you can have actually a recurrence rate up to 56% if the margin comes positive even after so much treatment, cryotherapy and all. And if you are treating an extensive OSSN and excising a big OSSN, then it can also lead to limbal stem cell deficiency and cause scarring and symboliferon formation. So that's the reason why medical therapy comes in role, and the treatment has been shifted towards topical therapy in certain cases. Because it has many advantages over the surgical management. That is, it actually avoids stem cell deficiency, and at one time it treats the large surface area, and you can easily repeat this therapy in these patients, and it directly acts over the tumor. And you can actually titrate the concentration of chemotherapy. You can reduce you can maintain with the low dose, or you can give the high dose when it requires. And it can help in treat the OSSN cases in a patient who is systemically ill. So the indication of giving these cases are very well defined, and you can use these topical chemotherapies in 3 ways. One is the therapy, chemotherapy. Second one is the chemo reduction, and third one is chemo prevention. Chemotherapy you can give in a cases when the OSSN is small, and if it is involving the pupillary axis, or if it is involving more than 2 or 3 quadrants of limbal stem cells. Chemo reduction, when there is a giant OSSN and patient is not fit for surgery, then you can just do a chemo reduction and then go for surgery. Chemo prevention, when the tumor margin comes positive, then you can give a adjunctive topical chemotherapies. Other than that, if we see histologically, then dysplasia and carcinoma in situ are the histopathological signs which actually respond to topical chemotherapy. In squamous cell carcinoma, we won't prefer this therapy as a first choice. Recurrent multifocal tumors are really very good indication for this part of treatment. Other than that, systemic factors like the patient with xeroderma pigmentosa, they used to have very recurrent OSSN, multifocal OSSN. So these patients can be treated with the topical chemotherapy. OSSN in HIV can be treated, and the patient who is systemically ill or of extreme ages, you can treat with this topical therapy. So what are the medicines treating these patients? Three main therapies we use for treating these. One is topical mitomycin C, which is we can use in a form of 2 concentration, 0.02% and 0.04%. And the treatment cycle would be 1 week on and 1 week off. Another one is topical interferon alpha 2B, and it is also, we can use in 2 concentration, 1 million international unit and 3 million international unit. 3 million international unit can also be used as a subconjunctival therapy. Topical 5-FU is as used as 1% and 1 week on and 3 week off. Another therapies are also available like anti-VEGF drops or retinoic acid, but they are infrequently used and most commonly use these 3 drugs. So in management of OSSN, I would first like to start topical interferon alpha 2B because it is most ocular friendly drug. And these interferons are actually a group of glycoprotein that promote the antiviral and anti-tumor properties and has immunomodulatory effects. The success rate is documented 80 to 100% with these topical interferons. There are a few cases I'm going to show that responded very well. And this was the first case I have shown in the first slide. It was actually squamous cell carcinoma. I did incisional biopsy in this and found it was squamous cell carcinoma, but the tumor was involving the whole interpalpable area and part of cornea, so I didn't go for excision. I just tried topical interferon first, and then this patient got a very good response, and within 3.5 months, patient, all part of tumor has completely disappeared. This was another case in which we started topical interferon and the tumor completely resolved. And after that, I could see the sign of the scar mark for incision size of this SICS. These cases, these are the leukoplakic ones with keratin plaque. These actually, they don't respond very fast, and sometimes they respond only partially with interferon or any other chemotherapies. With the experience of this topical interferon, we also published one paper in 2015 when we found the response rate was 91.6%, and the median time of resolution of this tumor was around 3.25 to 3.5 months without any significant complications. Another topical therapy is topical mitomycin C. It is very rapidly acting drug, and it also can be used as a primary therapy or adjuvant therapy in a post-operative phase, and it also documented as a 90 to 100% success rate. There are a few cases which were treated with the mitomycin, and they have very rapidly acting. So all the lesions resolve within a 1 or 1.5 months. But at the same time, it is very toxic drug also. It causes a lot of conjunctival congestion and epitheliopathy, and some paper has also been documented like the punctal stenosis and involves PED, and for which we did AMG in these patients, and it was not resolving with other drugs. So after that, after experiencing this complication, we just started the loteprednol along with the topical MMC, and that makes it slightly better. In 2016-17, we just compared the outcome of both interferon and mitomycin C and found that though interferon was taking a longer time for resolution of these tumors, but it was quite comfortable and patient can continue this drug for 2 or 3 months without any single complaint. But in mitomycin C group, though it's rapidly acting drug, but patient always complain of something. And the complication rate was really very high with the MMC in comparison to interferon. But at the same time, some tumors which were not responding to interferon, they responded well to MMC too. Third drug was topical 5-fluorouracil, and it is also a very good drug, and it has some peculiar feature, like it is very inexpensive. It doesn't need any refrigeration, and it is only 7 days you have to give in a month. Means its treatment cycle is 1 week on and 3 weeks off. So patient has to just put this drug for 7 days, and 3 weeks he would be without any drug like lubricants and other things. It also gives a very good response and a resolution of tumor, and maximum 3 or 4 cycle we can give these with 5-FU. All these flat tumors resolve very beautifully with all topical chemotherapy drugs. But in this period, we have to look for certain things to know whether this topical therapy is acting or not, and go for the surgery. So we should look for some clinical features, some signs to know whether we should continue or not. So one is the response of treatment, and it can be measured by the sizing, whether the size is decreasing or it's as such, or height of the lesion and the vascularization. So any topical therapy can cause the complete resolution of tumor or partial, or may cause nothing. These patients also have a recurrence rate. We didn't find any significant recurrence in our patients. And one very important criteria to look for in follow-up period, that is toxicity. And it is very common with MMC and 5-FU. The best one is interferon. And it can be present in form of redness, foreign body sensation, epithelial defect. The only complication reported with interferon is folliculitis, that is follicular reaction. So during choosing the drug, we should look for many things like size of the tumor. If tumor size is very big or the tumor has a good height, then it's very unlikely that this tumor is going to respond with interferon. MMC might work in these cases. Morphology is very important, like gelatinous kind of tumor works very well with the topical chemotherapy, while the leukoplakic one respond very slowly with these chemotherapy, and sometimes they don't respond at all. We should also look for the ocular surface. If the person has poor ocular surface or dry eye or this thing, then we should not go for mitomycin and 5-FU. Cost, the interferon is definitely very costly drug in comparison to the mitomycin and 5-FU, and we should also check the compliance, whether the patient is going to come back to us or not. If patient is living very far, then better to have one surgical excision and do amniotic membrane grafting with this cryotherapy. So in summary, I can say that there is a changing trend in OSSR management, and with the advent of high resolution OCT, as well as the introduction of this topical chemotherapy, which have been proven very viable option in the treatment of this OSSN as a primary or as a chemo reduction or as a post-operative therapy. Thank you for kind listening.
Thank you, Rakhi. I would like to have some questions. Number one, what is the incidence of conjunctival or sterile perforation in mitomycin C?
Sir, for last 6 or 7, 8 years, we have been treating the patient with mitomycin C, preferably interferon, not mitomycin, but I haven't seen any case of scleral thinning or melting with mitomycin C, with 0.04% concentration.
Okay, and how long you continue the treatment? Just suppose the lesion has already regressed, the complete resolution. So do you continue for a little more time?
As this drug is very...
Now I will stop the treatment.
Sir, as this drug is very toxic to the ocular surface, so till the clinical resolution of the tumor, we continue the mitomycin C, and after just complete resolution of the tumor, we stop the therapy.
And what is your usual schedule of follow-up? When do you call the patient for follow-up? And how long you will like to have follow-ups?
It depends upon what kind of tumor you are handling. Like in a case of flat lesions or not a very large lesion, and if the patient is on interferon, then monthly follow-up. And if the patient is on MMC, then we know already that these cases will come soon and complain of something. So fortnightly visit we do in these cases.
You said different doses of interferon. So are they available commercially, or you make it from 5 million?
Ma'am, here only 1 million international unit is available. 3 million international unit is not available in Bihar, as far I know.
How you make it? And
so, ma'am, interferon for topical therapy, it is available in a 3 million international unit it is available in 1 ml. So we have to just add 2 ml of distilled water to make it 1 minute. ₹800. So patient, the whole therapy would be one vial. Actually, it works for 15 to 20 days. So roughly, you can consider the whole of ₹4,000.
And you make it from 3 million and add 2 ml.
2 ml of distilled water.
Okay, thank you so much.
How many times you give?
4 times a day. Interferon actually 4 times a day continuously till the clinical resolution of the tumor. Or MMC has a treatment cycle. MMC and 5FU has a treatment cycle 4 times a day, 1 week on and 1 week off.
But there's some, you can give 2 weeks on, 2 weeks off also.
Yes, there are some studies, there are some people who are doing with this treatment cycle.
I am giving 2 weeks on, 2 weeks off. They're
yes, you can give, sir. It also work well.
Yeah. So
is there any maintenance therapy you are following? Is there any maintenance therapy you are following? That is one. And second is the role of cyclosporine eye drops.
So there's no need of maintenance therapy, because once the tumor has been resolved, you can check it by impression cytology or this thing, or if you are finding any cells still left there, you can still continue with the same therapy. There's no need of decreasing the dose or...
Okay, thank you, Dr. Rakhi. Because we are already running late, still 4 presentations are there. So now I hand over the mic to Dr. P Kashyap for the next papers.
Good evening, everybody. All the talks have been very, very nice and interesting. और सब कुछ क्वेश्चन पूछते जा रहे हैं. बंद Zoom वाला हम लोग को बंद कर देगा. इसलिए have to be a little faster. So let me introduce you to Dr. Praveen Subudhi, able son of a real good and eminent father, Dr. N R Subudhi. Real hero. Dono hero, sir. This handsome guy, he has done his MBBS from MKCG Medical College in 2004 with gold medal in general surgery. He has done his MS for Arvinda in 2009, DNB from in 2010, FRCS in Glasgow 2013, Cornea and Refractive Surgery Fellowship from Arvinda Eye Hospital, Mumbai in 2012. He had been consultant in cornea and refractive surgery at Arvinda Eye Hospital from 2012 to 2013. He had been the ICO fellow in cornea from in Switzerland in 2013. He had a lot of publications, numerous presentations, and he had been a lot of awards. And at presently, he is a chief consultant of Ruby Eye Hospital, visiting assistant professor at High Tech Medical College, Bhubaneswar. So handsome guy, Praveen, let's have it. Let's have you. Please talk. Please start.
Thank you, sir, for the kind attention, for the kind words you have said. Can you see my slides, sir?
No.
No. Is it visible now?
Yeah.
Make it slideshow. Good.
So good evening, everybody. I think we are running too late now. So the topic which has been given to me is about LASIK. It's not that easy as it seems. I have been performing LASIK for last 10 years, though I have seen very less complications, but we need to be vigilant. We need to understand these complications will happen, and we need to know how to face it and how to manage it and safely, so that we can give a good visual outcome to the patient who has come to you with a hope to get a good vision. And mind you, when we are performing LASIK, we are performing this on young and economically productive patients who have a life ahead and who have a good vision beforehand. So if any complication happens, then there is a permanent scarring and permanent loss of vision, which you may not explain it to the patient, and you may land up in trouble in your practice, as we are doing private practice, and nowadays medical legal aspects have also come up. So we need to be very much vigilant. So these are my certain contribution to literature during my COVID period. I always compare LASIK with a female wearing high heels. We need to be very, very balanced. It seems very easy for the female walking with high heels, but if you ask the female, they know that what's the trouble. Any loss of balance will lead to fracture of their legs, will lead to back pain and so many things. So similarly, the same thing with the LASIK. And the background of LASIK is the full form of LASIK is a laser assisted in situ keratomileusis, which is called as corneal remodeling. It uses excimer laser, the argon fluoride dimer. It has a wavelength of 193 nanometer. It's a gaseous state laser, and it's a flap related procedure. So these are the certain steps for the understanding of what I'll be speaking henceforth. We make a marking. We create a flap with the microkeratome. We lift the flap and we prepare for ablation. And you can see the ablation process is going on. And finally, we wash the debris and put the flap back. And basically, the complications of LASIK is intraoperative, that is flap related complication, and post-surgical complication. And the flap related complication can be divided into three components: the buttonhole, free flap, and suction loss. So buttonhole, you can see whenever in cases of steep corneas, if there is a blunt microkeratome, in those cases, if you perform flap related procedure, you can see here there is a buttonhole happens. Buttonhole means in the center, if the buttonhole happens in the center, then you should abort the procedure, put the flap back, wait for 3 months, and go with a thicker flap. In cases, if you feel that the buttonhole is periphery, you can go ahead with a shorter ablation zone. And sometimes you can also perform PRK. Free flap, again, another complication where you usually have a hinge, whether it's a nasal hinge or a superior hinge, and sometimes it passes completely and the hinge is not there and the flap comes out. In cases of free flap, you can go ahead with the procedure, put the flap back, and put a BCL at the end of the procedure for 3 days. Within 3 days, the flap adhesion happens, and you can nicely remove the BCL, and you are saved. You have no problem in that. Basically, free flaps happen when there is a flat cornea, and when there is a mismatch between the keratometry and the suction ring. So you need to be, this is the important thing. So whenever you choose the suction ring, you need to be very careful and what is the keratometry is, and accordingly you have to put the suction ring. If there is a mismatch, then it can lead to a free flap. Incomplete flap, whenever the patient squeezes his eyes, there may be a suction loss, and when the suction loss happens, the flap may be partial. In those cases, if it is involved, if it is not crossed the pupil, then again you have to reposition the flap back, wait for 2 to 3 months, and go with a thicker flap. But in case if the flap has crossed the pupillary plane, pupillary margin, then you can go ahead with the LASIK with a shorter ablation zone. Mind you, it's better to put the flap back, wait for some time, and go with a complete procedure. Shorter ablation zone will have a lot of post-operative symptoms like halos, glare, and all those problems. The patient will again never be happy. Because again, the patient has come with a hope that you will give him a better vision. And if you reduce the ablation zone and if you give him glare and halos, he will never be happy. He will never be satisfied. And ultimately you will lose your refractive practice. Because mind you, for the refractive practice, the word of mouth only spreads. If you do good to the patient, the patient will tell 3 other people. So in that way only you can improve your practice. But if one patient is unsatisfied, he will tell 9 other people, don't go to that hospital. Post-operative complication, again, epithelial defect, very rarely seen, but it is seen if there is overuse of anesthetic drops, and when you accidentally trauma the epithelium with the help of spatula, or the trauma happens during dehydration or drying of the flap. If it is less than 3 mm, then you can just give preservative-free antibiotic drops for a few periods and it heals. But if it is greater than 3 mm, then it's better to give a BCL and antibiotic drops. Mind you, in these cases, even if the epithelium heals, you have to continue with the lubricating drops to promote the adhesion of the flap to the stromal bed. Otherwise, there will be a little bit of a gap. So it's better to continue formation of the flap with that of the stromal bed. Flap stria is another complication which we see rarely, but we see. It usually happens when there's a misalignment of the flap to the stromal bed and the patient rubs his eyes in the first post-operative day. So you have to explain this is very important because you have to explain to the patient immediately after the surgery not to touch their eyes. If he accidentally touch their eyes, the flap may displace and there may be wrinkling formation. If wrinkling remains for around 24 hours, it becomes permanent and it's difficult to iron the flap, iron out the wrinkling is very difficult. And the patient will have an irregular astigmatism and unsatisfactory vision. So in case of, if you immediately detect there is flaps, wrinkles are there, you can take it to the operating room, iron out the flap and put it, iron the flap to remove the wrinkles and put the flap back. But if you detect late, then you have to do ironing or you have to remove the flap, iron out the flap, you have to do an epithelial removal and put a BCL also. Epithelial ingrowth is another complication which we rarely see. This happens usually when there is a blunt microkeratomes pushes drags the epithelial cells to the interface, and sometimes during irrigation of the bed, floating epithelial cells and enter into the interface. In these cases, the epithelial grows into the interface and it may hamper the vision. In these cases, you have to just lift the flap. You have to just lift the flap like this. And just remove the epithelial cells and put the flap back.
Ruko beta.
Diffuse lamellar keratitis is another complication which we see rarely. It's basically a sterile inflammatory keratitis which occurs due to the talc from the gloves, oil, meibomian gland secretion, povidone iodine, debris from ablation and epithelial defects. There are various stages of diffuse lamellar keratitis in the periphery. Stage 2, which comes to the center. Stage 3, there is development of a corneal scar. And stage 4, there will be wrinkling of the flap. Stage 1 and 2 can be treated with steroids for 6 weeks, which may suffice. But stage 3 may require lifting of the flap and washing out the stromal bed with BSS to remove inflammatory markers. Stage 4 is difficult to treat. It may lead to a permanent scar, and it is very difficult to explain it to the patient. Dry eye is another important complication which we see. In my practice, for all the LASIK patients, I put the patients on lubrications for around 6 months. Yes, why the dryness happens is because we nerves are cut when we create the flap. Because we have not detected the dry eye prior to the surgery. Hence, it is very essential for all the LASIK surgeons to identify these patients beforehand. Because if there is a dryness in there beforehand, then we have to address the dryness initially and then go ahead. Also, the lubrication guidelines needs to be continued for around 6 months to 1 year. Now we are performing the new software which I have in my clinic. This is called the IDRA Ocular Surface Analyzer, which identifies, which has a documentation of the dry eye. And with this dry eye, I can identify whether in the LASIK patients is the corneal ectasia. Here, I would like to share one of my patient, a 25-year-old male with a defective vision in both. He had came to me with a treatment for -2 and -3 diopter. His myopia was stable for 2 years. Pentacam showed normal parameters except for corneal pachymetry, which was a little bit thin. I thought of going ahead with the LASIK because it was -2, -3. I had a comfortable stromal bed of 350 microns. So I thought I was safe. The surgery was uneventful, and post-surgery patient had a vision of 6/6 in both eyes for around 3 years. And next, this was the preoperative topography of the patient. You can see it was very fine. It doesn't show any much except for the corneal thickness, which is less than 500. But otherwise, belly ambrosia, the anterior and posterior floats are also was nice. And the corneal thickness, spatial profile, and percentage thickness increase was within the 2 standard deviation. Everything was normal. But after 2 years, in the 3rd year, the patient has this picture. So bilateral patient has developed a post-corneal ectasia, and the patient's refraction again reached -2 diopters, and patient is again unhappy now. So for me, it was difficult for me to explain it to him that these things happen. But we need to be very much careful when selecting the patients for refractive surgery, because these type of complications may happen and you need to know how to handle it. This patient, I thought of going ahead with the topo-guided photorefractive keratectomy with partial fluent CXL. The purpose of this just to give a regular corneal surface. As post this procedure, the patient had a little bit of regular corneal surface, and patient has an unaided vision of 6/12. He's relatively happy, but not completely happy. But I am also a little bit satisfied, so I could give him some good vision, because in the case of before surgery, the patient had a vision of 6/60, which was very bad, and patient was not happy. After this procedure, patient has a relatively good vision with an unaided vision of 6/12. Post-LASIK ectasia needs to be taken very seriously. You need to have a proper history taking prior to the procedure. A family history is very, very important. In case of suspicion, you should not go ahead with the procedure and do a senior corneal topography so that you can see whether there is any changes there in the topography or not. In certain cases, even for the -3, -4, I prefer to perform a phakic when there is a case of suspicion. I bypass the cornea. And at the end, you have to expect the unexpected and try to address the situation articulately. Microbial keratitis is another dreaded and the most dangerous complication in the post-LASIK procedure. I have not seen in my clinical practice of last 10 years of LASIK, but still this thing can happen. You need to know. Because the problem is these keratitis are recalcitrant to any form of treatment. It is very resistant to treatment and difficult to isolate the organism, because it is under the flap. How to isolate it is very difficult. So it happens usually when there is a usage of unsterile microkeratomes, faulty BSS, and when there is an infection in the lid and adnexa. So you need to handle these cases prior to the procedure, and you have to see whether the patient is not harboring any infection in the lids. And in the microkeratomes, nowadays, you should not repeat use in other patient. You have to use in a single patient. In this COVID times also, it is very, very dangerous if you transmit the infection from one patient to another. That's why it's very essential to use microkeratomes for one patient only. At the end, I would like to say, beware, LASIK surgery is done for the economically productive people, and they have a whole life ahead. Minimizing complications requires a meticulous and a mindful approach. In this tough COVID times, we need to be vigilant to prevent cross-infection from patient to patient, patient to doctor. Post-LASIK ectasia is the dreaded complication of LASIK, hence it is prudent to carefully screen your cases and learn to say no to your patients. I know that it's a huge investment. You have to get the investment back, but it is very essential to learn to say no. And because it's a financially draining surgery and with zero tolerance to any form of complications, hence I would say it is not easy as it seems. So thank you very much for the kind attention.
Thank you, Praveen. It was very concise, and you have enumerated everything and all possible complications. On a lighter note, मैं तो बताता हूँ, you have said so much that if people are not doing LASIK, they may not dare to start doing the LASIK. So, but then, young, handsome guy, very nice, fantastic. We are running short of time, so I want to ask Dr. Bharti, I'll ask you to please tell us some solution. If you find the person to be fine, everything is fine, you do the operation, and then the patient develops ectasia. What do you have in your mind? Could you please tell us?
So, a very nice presentation, Dr. Subudhi. Had it been presented to me, I would, instead of doing early intervention, I would have kept the patient for follow-up at least 6 to 8 months. And every 3 months, I would have done the follow-up with refraction and topo. And suppose everything is stable, then I would have continued the patient's. First, I would have given him RGP contact lens for immediate visual improvement. And then if after repeated follow-up, if I would find that everything is stable, I would have given him solution of RGP contact lens, either continue with it or go for the phakic lens. And if it is progressive and I find that it is progressing, then I would have done CXL. And then again, I would have followed this patient for stability. And if the patient is stable, then again, phakic IOL. It is very good choice for patients. And one more thing is CXL. When you do CXL, such small cylinder, 1 and 1.5 cylinder is taken care of. You don't need to do anything on the cornea.
Yeah.
And another thing,
in this case, I I did not go for any refractive correction. Just a
I know. You did just topo regularization.
Yeah.
So, and the other thing is that for prevention part, when we take up LASIK cases, 4 things to prevent ectasia is a must. If we have a corvis, then we have to see the corneal biomechanics and topo guided biomechanics. Second, superior and inferior matching. Third, higher order aberrations by eye trace and coma, etc. And the fourth is family history and rubbing. These things are very important. How many of us assess vitamin D level before the surgery? Because that is also important to see the vitamin D level before the surgery. So I don't know how many of you are doing it, but I am doing it.
And he has said so many things he is doing. He has enumerated all those things. Very nice. So can you proceed to the next speaker?
So, I think the whole sessions are running very late. I'll ask moderators not to take any further questions.
Okay.
It is already 10 at night.
So Dr. Gyanankar Mehdi, he is a consultant of cornea and anterior segment services in the Eye Care Center, Guwahati. He had been trained for the cornea and anterior segment fellowship at Sankara Nethralaya, Chennai, and in Sri Shankaradeva Nethralaya, Guwahati. The cornea and anterior segment ICU fellowship he has done at Massachusetts, at Boston, USA. His area of interest is lamellar canal corneal surgery, keratoprosthesis surgery, cataract and refractive surgeries. So probably he'll be talking today about the Boston keratoprosthesis. Well done, Dr. Mehdi. Please go ahead. Come with your talk.
Good evening, sir. Thank you for the introduction. Let me share my screen. Okay, can you see the slides?
No, yeah. Yes.
Okay. At the outset, I'd like to thank Eizoc
for the slideshow mode. Slideshow mode.
Yes.
Yeah, good.
Thank you. At the outset, I'd like to thank Eizoc.
May I request all other people to keep your the video in a mute mode?
Okay.
Please go ahead.
Yeah, thank you. So I'd like to share our experiences of Boston keratoprosthesis. No financial interest. The concept of an artificial cornea is almost 200 years old. It was in 1789 when Pierre de Quincey first described the keratoprosthesis. That was during the time of French Revolution. In 1855, Nussbaum first reported human surgery with a quartz crystal implant. Now, there have been different types of synthetic cornea being pioneered and developed. Of these 3 main which are being used are the Boston keratoprosthesis, the alpha core, and the osteodonto keratoprosthesis. Of this, the Boston keratoprosthesis is the most widely used type of keratoprosthesis. It has evolved from the original concept to an established device over the past 50 years under the lifetime leadership of Professor Claes Dolman. The device was approved for FDA marketing in 1992, and based on the design, we have 2 basic designs, the type 1 and the type 2, of which the type 1 is most commonly used. Today, I'll be speaking on it. So it's a collar button design and it has three components. In the front, you have the front optical stem to which the donor cornea is placed, and then you have the back plate, and finally you have the locking ring to which you can lock the entire process. So when is a keratoprosthesis advised or when is it indicated? We all know for corneal blindness, corneal transplantation is the treatment of choice, but there are certain situations like where we have multiple failed grafts or where there is a case of high risk of keratoplasty failure, such as in vascularized cornea. In situations like aniridia, where keratoprosthesis is advised as a primary procedure, or in certain situations where ocular surface disorders in the milder form, we can do a Boston keratoprosthesis. For all of this, it's the last resort for bilateral end-stage corneal blindness. So it was more of a need-based thing when we started doing the Boston keratoprosthesis, because when I'm based in Guwahati, the nearest place when one has to go for a keratoprosthesis was Kolkata, where Dr. Basak was doing. So I started to develop these services in our part of the country. The keratoprosthesis surgical technique is basically of two parts. First is the assembly of the implant, and next is the surgery on the recipient. The assembly of the prosthesis is like you have to punch out the donor corneal button of 8.5 millimeter, and in the center of it, you have to punch out another 3 millimeter opening. The optical stem is then placed, the donor cornea is then placed in the optical stem. On the back side of it, the back plate is positioned, and then you place the titanium ring, which is snapped into it to form the complete assembly. And the surgical part on the patient is similar to a normal penetrating keratoplasty, where you remove the diseased cornea, and if there's a cataract, you can remove the cataract. And if it's a clear lens, you can also remove the lens, but then you have to choose your implant accordingly, because there are two types of keratoprosthesis implants. You have your pseudophakic implant and a phakic implant. Now this is one case in one of our series which had a large therapeutic keratoplasty, a failed graft, and other eye was blind also, so we had to do a keratoprosthesis for him, and he was having a good vision of 6/12. Now post-op is very similar to a keratoplasty surgery. You give steroid antibiotic eye drops, lubricants, anti-glaucoma treatment. The patient has to be on a BCL lifelong, and it has to be changed periodically. And one of the most important thing of keratoplasty surgery is regular follow-ups. We published our work in a Tamil Nadu journal where we shared our initial 10 cases. These were the 10 cases, and if you can see, we followed them up to 1 year with an average follow-up of almost 26 to 27 months, and all of them had a good working vision. In one case, we had a K-Pro extrusion, which meant the cornea melted and the K-Pro was extruded. So in one case out of 10 cases means in 90% the implant was retained. If you compare with other studies, we can find that the implant retention rate is also similar, 85, 84%, 80%. We have a large series of 141 cases by Jardu et al. With a good implant retention rate, and also a smaller series but with a longer follow-up of implant retention rate of around 80%. The most commonest complication being the retroprosthetic membrane, which was similar in our cases also. So this patient turned up this Monday after he is of a longest follow-up. He has been after surgery of 7.5 years follow-up. He had undergone an Ahmed glaucoma valve also. At present, he is maintaining a 6/24 vision and maintaining his day-to-day life. We had our own share of complications. We had retroprosthetic membranes which we had to treat with YAG laser. We had incidents of keratitis, which thankfully responded to very intensive topical antibiotic therapy. And then sometimes patients come with decreased vision, and when you find that the BCL has become dirty and there are deposits on it, when you change the BCL, they get back the original vision. Even under the BCL, sometimes you might get a teal defect, which needs to be treated very meticulously. And then you can have angle closure, secondary angle closure, because this is a crowded space, the antechamber becomes crowded, where you need to take care of the glaucoma part. Then we had 2 cases of ocular surface disorder where we had done the keratoprosthesis under the pannus, and then in these situations the conjunctiva grows over the optical stem, which and then you have to trim it so that the patient gets back the vision again. And this was the case that I just showed in the previous slide, who had to undergo an MN glaucoma valve to retain his vision and to keep the IOP under control. So we had experience with 3 different types of keratoprosthesis. The Boston keratoprosthesis mainly, and this the Oro K Pro, which is our own product, India-made product, is fashioned similarly on the Boston K Pro, and also Lucia keratoprosthesis, which is like a variant of the Boston keratoprosthesis. We had excellent visual recovery up to 6 times from initial pre-op vision of counting figure of hand movements. We had our own share of postoperative complication, but then we can monitor them and we have to manage the patient for a long-term basis. So to sum up, it's the last resort surgery in bilateral end-stage corneal diseases. The proper case selection is most important to give a good result. High compliance from the patient and dedicated follow-ups is a necessity, and it's a lifelong commitment both from the surgeon and from the patient. I would like to acknowledge my ex-colleagues from Sri Shankardev Netralaya, Dr. Kalyan Das, Dr. Agarwal, who is in the panel today, and Dr. P. Sharma. I've left Shankardev Netralaya. I'm in my practice now, but most of the cases that I have shown here were done during my tenure in Netralaya. Thank you so much. If there are any questions, I'm open to any questions.
Dr. Gyanankar, you were just superb, and we are so happy that a lot of people using this keratoprosthesis things. And you are using one type, you can use also the second type. Probably you need more cases to be referred to you. We will do that, sir. And keep it up. And we are so happy that our younger generation is doing fantastic. We couldn't do that keratoprosthesis. So thank you very much. I don't think I'll take any questions. I move on to hand over the mic to Dr. Sunil Kumar.
Yes, sir. Good evening, everyone. So our next speaker is...
Yeah, carry on, sir.
Yeah. So our next speaker is very young, dynamic girl from the Ranchi, Jharkhand, Dr. Nidhie Kashyap. She has done the MS Ophthalmology, DNB, MNAMS, FICO, ICO Cornea, and FRCS Glasgow. She did the long-term fellowship in the cornea and external disease from the Desai Hospital, Barrackpur. And she is currently heading the cornea services at Kashyap Memorial Eye Hospital, Ranchi. And she has a keen interest in the corneal transplantation, and she is doing the lots of the keratoplasty, including the lamellar keratoplasty. And she is doing the lots of the DSEC, DMAC, and the DALK also. So today she will be speaking on the DSEC, that is the descendant stripping endothelial keratoplasty, which is a very promising surgical procedure, especially for the patient with the PBK or ABK or fixed endothelial dystrophy. And it gives very gratifying long-term results if done correctly. So now I invite Dr. Nidhie Kashyap for a talk on DSEC in different scenarios. Over to you, Dr. Nidhie.
Good evening, everyone. Sir, am I audible?
Yeah, you're audible. Please carry on.
Thank you, Eizoc, for giving me this opportunity. About DSEC in different scenarios. To start off with the preoperative evaluation, the duration of symptoms is very important, and we should ask the patient about how is the vision. If the vision was low from the very onset, then it suggests that it was already a complicated surgery or the patient had an early decompensation. Looking at the epithelium, we see that there might be bullae which are painful, and there is always a risk of rupture with secondary infection in such cases. So bandage contact lens should be given or topical antibiotics should be continued until the surgery happens. There may be associated epithelial hypertrophy in chronic cases or subepithelial scarring. For example, this case, the visualization of the anterior chamber is not very clear, and we might think of going ahead with a full thickness keratoplasty here. But on doing the anterior segment OCT, it is seen that only the epithelium is hypertrophic. Thus, as a first stage procedure, only the epithelial debridement with a bandage contact lens was done. And you can see that on peeling off the epithelium, the underlying stroma is quite clear for an EK procedure. This is the pre and post-operative OCT of the same patient. Looking at the stroma, ASOCT has to be done and pachymetry has to be done. In cases where the thickness is more than 1000 micron, it may be difficult to clear with EK, or the recovery time would be a little more than normal, which has to be informed to the patient. There can be associated stromal scarring, which might be mild, moderate, or severe. In case of severe stromal scarring, we might have to change our plan to a full thickness keratoplasty. Looking at the endothelium and descendant membrane can give us some idea of the etiology of the decompensation, like gut data seen in Fuchs endothelial corneal dystrophy, vesicular changes and bands seen in posterior polymorphous corneal dystrophy. In cases of decompensation after TAS, we can see that there is a lot of pigment dispersion on the endothelium. And in case of decompensation after viral endotheliitis, some old keratic precipitates can be seen on the endothelium. It's not very clear in the picture though. Areas of DM scarring should be seen and observed because these might be the incisions of the previous surgery. These areas of scarring, it is difficult to score the DM, and these areas, it is more likely that a graft detachment might occur. So if we have to plan the graft, we might make the graft a little eccentric and leave these areas. Now, in cases of failed grafts, we need to do the graft-host junction evaluation. As you can see in this first case, the transition from the graft to the host is quite smooth. While in the second case, there is a step deformity. Now, this deformity, if the graft extends beyond or it passes through this junction, then there is a very high chance of detachment at this area. So, when we see this graft-host junction, it helps us to decide what should be the size of the graft to be taken. And in this case, it should be well within the size of the previous graft. Again, looking at the anterior chamber, vitreous always has to be ruled out, and then look for nuclear fragments. These fragments might be present in the anterior chamber touching the endothelium, or they might also be present behind the iris and present as anterior synechia. And these small fragments usually occur due to chattering effect of very hard nuclei during phacoemulsification. So that has to be taken care of while doing the surgery. Peripheral anterior synechia should be looked for, and such areas have to be avoided for the incision making during the DSEC. Such synechia may also be present in ICE syndrome, and releasing them, some of them are easily released, but the stronger ones might be left as such because trying to release them, we might cause iridodialysis or bleeding, and they tend to reoccur again. Then few cases, we have to look very carefully for any broken haptic or decentered IOL. Sometimes with the edematous cornea, it is not very visible, but on the anterior segment OCT, we can clearly see that area and find out. The pupil also gives a rough idea of how the previous surgery would have been. It might be complicated, and thus the pupil would be irregular. There might be peaking of the pupil suggestive of vitreous in the pupillary axis. The pupil might be irregular in cases of ICE syndrome, or it might be fixed and mid-dilated in case of post-TAS decompensation. Visibility of the anterior chamber structures also is important before doing the surgery. In cases of shed, this is a little lower, and thus in this cases, people prefer DSEC versus DMEC because comparatively a little blind procedure can be done in DSEC, but DMEC we need a proper visibility. Other things to ponder upon is the IOL status, whether it's an AC IOL or a PC IOL in the sulcus or in the bag. If the haptic is broken or the IOL is dislocated, or if the patient is aphakic. In the fundus, if the view is clear, always do a OCT central retina to look for any cystoid macular edema. And if it is too hazy, then a B-scan ultrasound should be done to rule out any retinal detachment due to vitreous traction in a complicated surgery. IOP has to be managed well preoperatively, and you also have to look for any bleb or any glaucoma drainage device. If there is a true tube which is touching the endothelium, that needs to be trimmed, or it needs to be relocated to a pars plana site. Tissue selection, the endothelial cell count should be more than 2500 cells per millimeter square, and preferably phakic with no DM scars. And there should be a regular rim for at least 2 mm for the tissue to be mounted properly on the artificial anterior chamber. Again, preoperatively, IOP can be lowered with injection mannitol. Some people are using 10% glycerine eye drops to improve the visibility, and brimonidine eye drops to reduce the bleeding during the procedure. In pseudophakic patients, pilocarpine should be used to constrict the pupil and dilate the pupil for combined surgery, which can later be constricted again. Inferior PI and DSEC is a surgeon choice. It can be done preoperatively as a YAG PI if the visibility is good, or it can be done intraoperatively as an external surgical PI or via the vitrector. So in the planning, important things that I would keep in mind is what incision site or type that I want to take. If I have done the PI, or do I need to do the PI in that case? Will vitrectomy be required? Will I need an IOL for exchange? Do I have a backup tissue? And always explain the patient for the need for rebubbling in the coming days in the postoperative term. The surgery can be done as a two-stage procedure. Cases with epithelial hypertrophy, any IOL exchange, SF-IOL to be done, or in cases of viral endothelitis, in which first we would want to take a tap from the anterior chamber and do a PCR to rule out if the disease is active, and then when it's negative, then proceed with the EK procedure. And combined procedure can be done when it is associated with cataract in other situations. The IOL power calculation, we have to overcorrect by 1.25 to 1.5 diopter, considering there is induced hyperopia due to the lenticule. Keratometry can be done from the other eye, and if there is a plan of IOL exchange, then the previous IOL power can be used as a guide. So starting the procedure, we have a guarded diamond blade knife. The tissue is mounted on the artificial anterior chamber and the epithelium is debrided. The incision site is marked. A template is put 8.5 mm. The initial 1/3 dissection is done manually with a blunt crescent, which is then followed by a lamellar dissector. While dissecting, we have to take care that the dissection is completed up to the limbus, else there will be a difficulty in separating the two lamellae after trephining. For better visuality, epithelial debridement is done and tissue sizing has to be decided. This is a 8 mm template. The side ports are made, and we have to take care that the inner lip of the side port is outside this template. It should not overlap, else the graft will touch every time you enter the anterior chamber. Incision, the entry can be either clear corneal or corneoscleral tunnel. I prefer the corneoscleral tunnel. And the entry is different from SICS, that it's a square configuration. We do not need to make the side pockets. After clearing the anterior chamber, an air bubble is put to see how the eye is going to behave on giving the air tamponade. After removing the air, then we stain the endothelium with the trypan blue, wash it, and then start with the DM scoring. So this is the example of how different type of eyes and conditions behave while scoring. This is a normal pseudophakic bullous keratopathy, in which you can see that the DM can be scored very easily and it comes out as one whole tissue. While this is a second case, which is post-end-of decompensation. So in cases with endophthalmitis and TAS, it is very difficult to score the DM. This case here, this is a case of failed graft in which we have decided to score the DM, but there was a very thick retrocorneal membrane. So that has to be removed, and along with that, there is an underlying layer of DM that also we have to remove. This has to be taken care in failed grafts. It is very commonly seen. In cases of failed DSEC or EK, it is easy to score the tissue, but while removing, we have to be very gentle, else there might be adhesions between the edge of the tissue and the iris, and while pulling, you might cause a iridodialysis. The tissue is trephined, And then a layer of Helon is placed over the incision site. The endothelium is placed down and the S mark is put. Here I am using the needle pushing technique. The graft is slowly placed inside. The anterior chamber deepened a little. And at this point, we put a very small air bubble just to keep the graft afloat. And this would have been the right time to put a suture, but I have put it a little later because while centering the graft, sometimes the tissue might just come out from the tunnel. If it is not centered on its own, a reverse Sinski can be used to center it. After securing the main tunnel and one of the side port with sutures, a full air tamponade is given and the patient is made to stay on the table for 10 to 15 minutes, after which an air fluid exchange is done. So at this point, the air bubble should be 60% of the anterior chamber and we have to check that it is mobile. And at this point, a dilator drop is put to avoid pupillary block. These are some of my post-operative cases. Thank you for your patient hearing.
Good, Nidhie. Very nice.
Very nice.
Excellent presentation.
Thank you.
I have a question, Dr. Nidhie.
Yes.
Like, if there is a case of post-operative decompensated cornea, pseudophakic, so how long should we wait before referring it to for some surgical intervention? Like the cornea is decompensated and not improving. So is there any waiting time or should the patient be referred within a short span?
So initially, we just need to establish the cause of the decompensation. If it is not acute like TAS or ENDOF or any DM detachment which is there, which is missed, if none of them is there, then we can wait up to 3 months and see. And if it's not improving, we can give a full course of steroids and then observe. And if not, then we would proceed.
Okay, thank you.
Dr. Sunil, you unmute yourself.
Yeah, Dr. Nidhie, I have one question. If the patient with PBK had the AC IOL, so do you always go with the IOL exchange or we can go with the AC IOL in certain patients?
So if the IOL is stable and it has been a long-standing IOL which is there in the eye and there is no vitreous in the pupillary axis, IOL looks stable, then we can go with a graft as well without exchanging it.
Yeah, okay, that's okay. So if there is no any other questions, then we can go to the next speakers. So our next speaker is Dr. John Sarkar. He is done the MBBS from the RG Kar Medical College in 2002 from the Kolkata and DO and MS. And he has done the Cornea Fellowships from the Sankar Netralaya, Chennai. And he is currently the consultant at the Sujoy Eye Foundations, Kolkata. And he had many presentations international and international levels. So today we'll be talking on the phaco in the compromised cornea, which is another very important topic because we all of us do the phaco, and many times the cornea is not clear. Patient has the corneal scarring and corneal opacity, even the corneal edema. So let's see, we all learn from his talks. So now I invite Dr. John Sarkar for his talks. Over to you, Dr. John.
Thank you, sir. Am I audible, sir?
Yeah, audible.
Yeah, you're audible.
Thank you, sir, for your kind words. First of all, I would like to thank Scientific Committee of Eizoc for giving me the opportunity for today's webinar. Without wasting time, I'm sharing my slides. Am I visible?
Yeah, you are visible.
Yes,
Please
you
go
are.
ahead.
Yes, visible, visible.
A very good evening to all of you. I'll be presenting phacoemulsification in compromised cornea. I have no financial interest. In present scenario, phacoemulsification is the standard surgical procedure for the cataract surgery going by leaps and bounds for the last decades. From its endeavor to fine-tuning, Indian surgeons we are now confident enough for the last 1 decade for handling the white mature cataract, brown bones and rocky heart cataracts. But sometimes if the patient comes like this condition with profound visual impairment with the cataract lens, with the pre-existing corneal pathology like this, like this, like that, or like this, then we are really confused whether I would go ahead with the phacoemulsification with these patients, because all those cases for the variable degree of the visual impairment and there's a loss of clarity. This condition is caused by most of the times with Fuchs endothelial dystrophy with centrally zero cell with the symptomatic patient. That means there's some sort of the decompensation going on these patients, or ocular surface dysfunction, follow-up or chronic sequelae of the SJS or post-Morens patient. Post-HS with scarred cornea with history of endothelitis with variable degree of vascularization or compromised endothelial palm function, or scarred cornea with a variable vascularization. This type of patient, when present, will cause a profound visual impairment with the cataract lens. They cause a profound bilateral blindness if not managed timely and appropriate manner. So before go ahead with the surgery, we should know the three basic questions: when, what, and which. When should I treat this patient for the cataract lens? What exactly the pathology for individual with this patient, and which technique, surgical technique, I will just adopt for this patient, whether phaco or something else, PCC or SLCS. Those patients are visually rehabilitated by improvement of the ocular surface hills or Pro's lens, but once there is a cataract is there, we have to do the cataract surgery. Cataract surgery often delayed or not attempted because there is sequelae or the post complication of debridement or the defect in the ocular surface or debridement of the ocular surface. So this presentation highlights the appropriate management and the outcome by phacoemulsification in compromised cornea. Before going to surgery, we should check the following checklist. There should not be surface inflammation. Surface inflammation should be controlled. Eye should be moist. Additionally, you can do the plug the eye, punctal plugging, or punctal cauterization. I do personally prefer these things to clear and to make the eye reserve pool of the tears. Corrected tear film instability or any lead pathology is there. It should be corrected addressed before go ahead with the cataract or phacoemulsification. Those type of surface disorder patient, IOP should be controlled. Sound positive segment should be checked by USG or IO, and the appropriate available power calculation is challenging the scarred cornea, and the rational surgical plan with a minimum tissue handling, and the team approach always welcome for this complicated scenario. This is one of my patients. I'm sharing the video. This Fuchs endothelial dystrophy with this patient with a centrally zero cell with the nucleus sclerosis. The video is visible.
Yeah, it's visible.
Okay, yes, yeah. There is centrally there the zero cell is there, and you can see I make them as it's leathery, almost grade 4 nucleus. I made little bigger access to reduce the stress on the granule, and all the steps I make a temporal clear condensation, gentle hydrogenation dissection. I prefer this patient for the stop and chop technique, the deep range, and intermittently I cover the protect the endothelium by dispersive vascular stick and prefer to crack it, but I'm not able to crack it due to dense nucleus character. I didn't ever hesitate to use the two instruments for this patient because I don't want any untoward effect for the complication for this patient, drop nucleus like those things. So I'm just using two instruments to crack it one. This is one of the modifications because it should not be hesitate this type of compromised cornea. This should be less stress or less damage to the endothelium, and I almost try to prefer in the iris plane. Intermittently, the endothelium is coated with the dispersive vascular stick and followed by a IOL implantation. This is the patient. You can see this is centrally the gutter is there, very obvious, and this is the almost 6 weeks poster with having the vision 6/6, and follow for the last 1 year without any decompensation. This is another patient. I personally, I'm just presenting this patient, these slides because this patient having 1 minute. The lady having the folks with the early decompensation. I was planning for this second one, this picture. I was planning for the combined procedure for the phaco dissect, but the lady is like economically down, and she is not able to bear the combined process. So she asked me to. Ask her to. I will do one thing. I just break up your procedure. I'll do the phacoemulsification. Try to protect your endothelium as much as possible with due respect. I just try to do the phaco, only phaco for this patient, and with every protection address to protect the residual pool of the endothelial cells. And you can see this is the 6th week post-op, and she's doing well, and almost more than 1 year follow-up. Now things, the lady is very happy. She's not able to, now we need not to go for the dissect, but I was really disappointed for that. But anyhow, she was very happy, and I have done the other eye too also, the same type of corneal decompensation. Now move on to the next slides. This is the Moran's patient. This patient having the Moran's, and she followed for the last 2 years. I had done the globicil almost 2 years back for the. You can see the superior gutter was there. It's involving from the 7 o'clock to almost 2 o'clock position. So no way to go doing the SSS from superiorly purpose, or you can even temporal also, because they're almost more than 3 o'clock hour involving. But the central cornea was clear, which helps me a little bit of easy this patient for. The central cornea is clear. The phaco is done. I was sitting in the almost inferonasal position, inferotemporal position, and stopping chop technique with protection of the endothelium. And one thing should be there. I should be quiet for this, and I should give the sufficient suppression for those patients. This patient actually, when I was operating earlier, she was in microfilm hospital with oral steroids. When I was operating, I was started the oral steroid 7 days back, and microfilm operating 7 days back before the surgery, and it's continuing almost 3 months post-operatively. And I never revisited to put sutures in the temporal part because the cornea is sufficiently thin. And sharing my post-op of this patient, you can see the gutter for pre-operatively, and this is the post-operative patient for the 6 weeks, and that is just having 6/6 and secretion and maintaining more than 6 months. Now move on to the next patient, that is the SJS patient. This patient having the intrascleral grade 2 with central corneal scar or cerebral vascular adhesion. We are planning for the phaco. This patient actually, we are using the rectal illumination. That is one of the clues for making your job easy during the intraoperatively, because as the central scar was there, I was almost done most half of the surgery by rectal illumination. It makes my job very easy. This part is a little tricky. But the thing is that once I have done the hydrodilation, my visibility again goes off with the gentle hydrodilation. You can see now the visibility become blurred, and it's really tough. In this scenario, if you have the endo illuminator, you can use it off. To use it off, just like vitrectomy surgery, they are using PPB endo illuminator. You can assist these things, which will make your job much easier. But I didn't have this one, so I just again, once the emulsification part is completed, you can see gradually there we can get the glow from the fundus. And again, I have to switch over to rectal illumination part for the IA part, irrigation aspiration part. Followed by IOL implantation. This is the pre-op patient, this patient having the post-op patient. This is one of the patient. I'm very much attached with this patient. This lady came with during the time of lockdown. She having the bilateral corneal scar, probably the keratomalacia origin. Other eye have the adrenal leucoma, but this eye is the only seeing eye which having the paracentral corneal scar. But that having the obscuring the vision due to the almost total intimation cataract, and not for the lockdown, for this cataract she is bound to be home. And when she came to us, we wheelchair bound. During the month of July or August early, we don't have the provision for doing the optical PK. So I thought that if she having the vision, I give some little bit of vision for her. So I was planning for the phaco for this patient. You can do the SSAs, but I try to make the eye virgin because later on, once it will be COVID, things will be over. We can plan for the lamellar keratoplasty for her. Once the cataract part is over, you can see how dense the macular leukemia scar of this one. So again, same thing I'm using here, rectal illumination for the IA pass. It is very, making your job is very easy. The scarred cornea, if you do in the rectal illumination, followed by IOL implantation. This is the same, you can see the scar. This is the post-operatively. She can manage now the daily activities and she is happy. We are waiting for the, if she wins, and we can plan for the lamellar keratoplasty later on. This is one of the, another patient which having the variable degree of vascularization with the scar for the, with recurrent history of HSV keratitis. And for the last almost more than 6 months when the eye was quite without any antiviral medication, then we planned for the cataract surgery because there is significant post PSC with NS2. And the problem is that during that day, I don't have the microscope, don't have any rectal illumination. It's really tough to do without any rectal illumination this type of patient. What I am using here, I just want to share with you. I asked the OT brother to just, at the time of the phacoemulsification, almost have done. But the problem during the IA part, as this machine microscope, I didn't have the rectal illumination part. It's really tough to make out in the skirt count, that's much skirt counting. I use a external illumination light, just which little bit of assist me. And I was cleaning the hair by IA, not in using the IA, the Simcoe, which by reflex I clean it off and put the lens and make a suture at the temple part and close the eye. So a discussion of preoperative thorough clinical examination and the surface inflammation should be corrected before going ahead with the phacoemulsification, those type of compromised eye. And the moist eye is a must. Preoperative proper surgical plan, flexible intra your decision making. It is not that I am very much rigid during the surgery. If you were planning for the phacoemulsification compromised cornea, you should be flexible during the intraoperative period. If you need some of the modification of surgical technique, you should not be hesitant to do the minor modification during the surgical intraoperatively. That will give you the ultimate maximum outcome. It is better to leave the conjunctiva virgin, and it is preferable to give the 3 millimeter clear cornea incision in this compromised eye, because which maintain the biomechanical compromise or compactness of the cornea, or neurosensory compactness of the cornea is better if you are giving only 3 millimeter clear cornea incision. So now we are scratching in our head that which technique should I adjust, SSC or SSCs, or we should go ahead with the phaco for this compromised eye. Definitely, if the cornea is permit, then to the health is permit. If the visibility is good, definitely I will go ahead with the 3 millimeter incision of the phacoemulsification. These are the published data. Though there is a not very huge series of the patients with the compromised cornea phacoemulsification, there is a larger series from the our mentor, Dr. Geeta here, madam, she having the 22 patients with the compromised cornea with ocular surface, and Dr. Sangwan sir having 140 patients out of 32 over the more than 10 years time, and definitely showing there are, I mean, the case series of patients showing there is a phacoemulsification is a desirable technique, and for the compromised cornea, because which will give you the less surface, damage. Post-operatively, you will get the predictable outcome, and definitely the patient recovery or early mobilization will be very good, because if you do the incision or if you damage the cornea, there is a high chance of the surface inflammation. So in conclusion, visual outcome after phaco in compromised cornea can be satisfactory across the different causes. Intraoperative modification of surgical technique and a team approach are rewarding in this challenging scenario. Appropriate post-operative medications and close monitoring with the patient. Even if required, we have to give every alternate to the patient, even of the and detection of the early decompensation, if any, and we should address properly. Don't hesitate to take any second opinion from your cornea colleagues if you need, and definitely you should be flexible for the surgical technique. These are the key to success for the frequent compromised community. Thank you. Thanks for your kind patience. Thanks, Eizoc, for giving the opportunity for sharing my
excellent
slides.
presentation, Dr. John. Excellent presentations with the excellent video. And you have shown the very good post of results also. So one question, what is the most deciding factor that you will do only the cataract surgery or the triple procedures in this, especially the advanced corneal scarring?
Sir, actually, being a corneal surgeon, definitely I would like to go ahead with the corneal surgery. But the condition, the surgery what I am showing here, see, some of the patients do have the first, if you consider one by one. The first patient, the first patient, if I can, definitely whatever I want to emphasize here, though there is a central zero cell is that during our fellowship 5 years back when we were learning, if you central zero cell, directly go ahead with that. This is zero cell, we go ahead with the dissect with combined phaco. But one observation is that if you have if you do the panorama mode of your specular SPM, specular microscopy, if you show that the sufficient number, good reserve of the endothelial, good healthy endothelial cell is there, and if you are very much surgically sound in your surgical technique, and if you do respect, if you do the endothelium, so definitely if there is no any decompensation, so why should I go with the triple? Because nobody, nowhere of the world can you give the 100% guarantee that there will be no rejection.
Yeah,
that is number one. And the second patient, whatever endothelium showing here, sir, this lady definitely, I was make up my mind that I will go ahead. I was very attached with this lady because the last 4 years she is followed with me. Somewhere else will come referred to me. I was initially planned for the combined procedure, and I was very disappointed because I was working in a corporate hospital. Nothing in my hand. They have the charges is little higher combined procedure to the second the phaco. Then she requested me. Then I was thinking what I can do for her. So I was specifically showing the second poster photo of this lady, and this is really complicated because she having your hyperopy, very shallow AC, already PI has done part of the paracentral zone. The decompensation is there. In spite of the all odd thing, I just tried to preserve the pool of the endothelial cells, whatever she having. And touchwood, and the post-operative, she was initially the mild corneal edema that was medically managed, and I was trying to not to damage the residual endothelial cells. And she's maintaining 6 by 12 vision. So definitely, being a corneal surgeon, I love this very much. But in spite of this all thing, if I can do the simple thing, why should I make the thing complicated? Number one. Number two, whatever asking, well, sir, you are asking the Morens patient. Now see this is my Morens video, whatever I'm showing here. There is a corneal scarring extending from 7 o'clock to the almost 3 o'clock. So there is no way to sitting in the superior position, making the scleral tunnel. I can make the SCC also. Central part of the cornea is clear. I have a visibility. And in almost 3 o'clock, there is a scar is there. So I can't see the temporal SSS also. So that is the only option there is that. And if you are definitely confident enough, to you can go ahead with the procedure for the Morens. With definitely one thing is the rule of thumb, you have to be give the immunomodulator during your or intraoperatively, post-operatively very nicely.
Yeah, you have to start the pre-operatively from there.
Yes, sir. Yes, sir. Yes, sir. And now, yes, sir.
One question.
Yes,
Suppose
sir.
if you encounter PCR in these cases, how will you manage PCR?
Yes, sir. This is a very nice, tricky question. Touchwood, I not yet face any this type of complication. That's why I try to be safe during my surgical technique. That's why the first slide, that was a very leathery cataract. And I was trying to protect the whatever the everything from the PC level, down level PC and the superior level endothelium. That's why first slide, I intentionally showed that but I can be hide that I am using the two instrument. I never hesitate to put any changing the minor modification. Whatever I want to emphasize, definitely I never encounter. But if you have the PCR, whatever I go through the slide, the study of the Sangaman sirs and our mentor, that Geeta madam, definitely one or two, there are series of patients in the Geeta madam, she having the 22 patients, the Sangaman and they having the 40 patients out of 10 years follow-up, they have a one or two incident among the series. Definitely they mentioned you have to do that just like normally. If you do that, definitely nicely enterovitectomy. If you have some of definitely, if you see if you can pull the sulcus is maintained, you can pull the hip I will. It's definitely, if you not, you don't put any, I will. If you are doubt, don't put any, I will. Make
Dr.
it the patient application.
Yeah, Dr. John, where do you keep your endoeliminator? Do you do with the bimanual technique with the IA or?
Sir, actually, where I'm working, we have is only cataract OT, endoeliminator in the VR OT. So I am not able to, I didn't use during my surgery. But whatever the literature saying and the experts saying, if your visibility is very poor, you can use just like your bimanual. When you are doing just like a chopper or Sinski, whatever you are using during the phacoemulsification, you can stabilize your these things. You can put the your one of the side port. You can use the Indo illuminator.
Now, what about IA? While doing IA, do you
No, sir. In IA, I use the retro illumination, sir. Retro illumination. And in the last patient, I specifically mentioned, sir, with due respect, what I'm telling, that actually that day I didn't have the your retro illumination, that microscope. That is a little bit of inferior quality microscope. So it was really very terrible and tough job, and I was not make it out. Then I will stop the IA procedure. I know I am very much confident about the your Simcoe cannula. I just go to backwards, use the Simcoe, and I asked the OT brother to use just show some of the light from outside. What the light they are using for the GA patient for the IV cannulation, that light is he was showing.
Okay. Thank you.
Yes, sir.
Yeah.
Any suggestion, any doubt? I will be very happy to answer.
I think we
excellent presentation and an excellent discussion, John.
Thank you, sir.
We have enjoyed it. Everybody, all of us have enjoyed it over here. But I think we should move on.
Thanks.
Quite late.
I would like to thanks entire Eizoc family for giving me the opportunity for the today's webinar.
I would rather request you to be part of our family, John.
I registered, sir, being a member.
Thank you so much.
So
let us move on. Sujoy?
Yes. After this excellent discussion and presentation, all the speakers were really brilliant, and I really enjoyed listening to everyone. So with this, I will move on to Dr. Subroto, who will be summarizing the whole thing and giving his closing remarks on today's webinar. Dr. Subroto, please.
Good evening. I don't know whether we should say good evening to all. It is heartening to see that the fantastic presentation of today's webinar. Actually, I am very delighted because I am being associated with Eizoc for so long from my residential days. So from the residential days, we have learned that we should handle with care. The cornea is a tissue where we should handle with care. And one of my professor was telling during his class, I still remember in our undergraduate days, that he used to say, the cornea you have to use or handle as the newlywed bride. So the talks are very, very excellent. Actually, nothing to talk about it. Where to strike, like Dr. Rajesh Sinha, Professor Rajesh Sinha, keratoconus advancement and surgical and cornea cross-linking. We have learned so many things. And he has rightly says the early detection with highest degree of suspicion and with frequent change of glasses is one of the tools of clinical diagnosis. Then beneficial and informative case presentation by Dr. Ravi is highlighting once again against the consanguinity. Dr. Rakhi, topical chemotherapy, insight of the drug and its details, we it will be in our mind for long. Dr. Praveen is excellent. Yes, LASIK is very, it's not that easy. And Dr. Nidhie, Boston keratoprosthesis, thanks for starting it in Assam, because I belong to Assam from my college days. That time there was no corneal surgeon in Assam. I still remember when I was doing my MS in some medical college developer. Dr. Nidhie, dissect is a very important thing, and you have started, and the Jharkhand is in the map of dissect now. Dr. John, you are excellent. The FECO in compromised cornea. Actually, we should think about, as the anterior segment surgeons, we should work in more to prevent all those things. For preventive, we should go for topical way. We should modify our incisions like from the 2-plane to 3-plane, or in the hinge type incision, or pre-chop incision, or pre-pocket incision, so that there is less corneal edema, cornea gets less traumatized. Sensible use of viscoelastics like sodium hyaluronate, and with slight modification of our technique with consumables, visco, and properly consumables like sensible use of viscoelastics, changing the phaco tips, the proper phaco tips in proper time, we can reduce the corneal trauma. So I shall end my remark with a quote like if you see something before surgery, it is an expectation. But if you see something after surgery, it is a complication. That's all from my side. So from my side, I come back to my initial saying that cornea should be handled with as a newly wed bride as delicately as possible. Thank you very much. Thanks for this in late night webinar meeting. Thank you.
Thank you, Subrata, for this excellent summation. Now I'd request our President-elect of JHOS, Dr. Lalit Jain, to give the vote of thanks.
Before you give the vote of thanks, I'd like to request Mr. Rahul to put up the phenopain slide. I'd like to thank our sponsors today evening for N R Pharmaceuticals for their proposal and sustaining our academic programs over the months. From the beginning itself, N R has been doing so with earnest motivation, and they have come out with the phenopain plus intracameral injection. The best part of it is rapidly dilated, almost 9 millimeters immediate dilatation within 20 seconds. So that is the best part of it, and I think all of us should avail this in our surgical armamentarium. With that, may I request Dr. Jain to move over to the vote of thanks.
Dr. Lalit Jain, please.
Nice, I have used it. It's wonderful.
Thank you.
Dr. Lalit Jain, please give the vote of thanks.
On behalf of Eizoc webinar, can you hear?
Yes, sir. Please go ahead.
Voice of East, Cornea Revisited. I thank our guest faculty, Professor Rajesh Sinha, our senior doctor, Professor P Kashyap, Eizoc President, Dr. Abhijit Ghosh, Secretary, Dr. Pranav Ranjan, Chairman Scientific Committee, Dr. Debashis, Convener, Dr. Samanta, President and Secretary, JHOS, Coordinators, Dr. Gupta, Dr. Kashyap, Dr. Sunil, all participants and speakers for making this webinar so lively and successful. Thank you.
So thank you, sir.
Everybody.
And
Dr. Rajesh, a word from you. How did you feel today's session?
It was a wonderful session. A lot of learning from some of the very good presentations, and I mean, it was very interesting. So in between, I missed a little bit while I was having something to eat.
You were having dinner, I know.
But throughout, I was, glued to the laptop, and I was listening to some of the very good presentations by our, young colleagues, and it was fantastic. Very good sessions. Congrats to Eizoc, and once again, a big thanks to Eizoc, because I mean, you all are so close to my heart. I mean, I belong to your family.
Professor Sinha, we are actually trying to highlight the younger generations. As noted, all the speakers today are basically the younger generation.
Yeah, they presented very well. Very nice presentation.
Yeah, that is what we are trying to build up.
Dr. Debashis, our voice is louder?
Yes, sir.
Yes, definitely.
Definitely, sir.
And
a word from our president, Dr. Abhijit
I would
Ghosh.
also like to say one thing, that if at all, if I can be of any help in taking Eizoc to a higher level, I will always be very eager to do anything, whatever you feel I can do for Eizoc.
That will be a great honor from
Rajesh, make the AIOS
Kolkata conference.
Yeah, right.
Already rocking. Abhijit sir is there smiling. It is rocking.
No,
a word from you, our president, sir.
Yeah, excellent. I was wondering that you people don't want to go to sleep. It's 10:30, 11, and you're all there. I was watching. There was not a loss of one participant also. So it must be great. So I was afraid whether late night would work. the next conference, we'll put it up to 12 o'clock in the night if you want.
No problem.
But say in afternoon, sir.
So it's so enjoyable. It's so lovely to see all the vibrant faces, young and old. So let us enjoy this way and let us have a great time together.
Yeah.
That is all I have to say. Let us enjoy the whole thing.
की बोला जाए अभी तो पार्टी शुरू हुई अभी तो वेबिनार शुरू हुआ
है अरे काश्यप এটা কলকাতায় হলে রাত্রিরে we would have some scotch together.
Yeah, you're right. Like before,
like the old times.
Yes.
Chalo, best of luck. Stay well.
Thank you, sir.
Stay well, everyone.
Congregation of young people.
Good night, sir.
So what? They are all.
Thank you, everybody.
Thank
you so much.
Thank you.
And good night, everybody.
Thank you, everyone.
Good night, everybody.